Good afternoon and good morning to those of us that are joining from the West Coast. Welcome to the Society for Academic Emergency Medicine's SAEM20 virtual meeting. I'm Dr. Emily Hayden, an emergency medicine physician and a director of telehealth within the Department of Emergency Medicine at Massachusetts General Hospital. I also am the chair of the planning committee for the 2020 SAEM Consensus Conference on Telehealth and Emergency Medicine. For those of you joining us for the first time, SAEM is the premier international organization representing researchers and educators in emergency medicine. In their work, SAEM promotes and facilitates scientific discovery, educational innovation, and the professional and leadership development of its members. Today, we are proud to bring you a special COVID-19 presentation, Telehealth and Emergency Medicine During COVID, Lessons Learned. We're excited to have you here. So telehealth has exploded, but honestly, I probably don't need to tell you that. You've seen it all around. From the 12-fold increase of virtual visits for respiratory complaints to entire medical practices that have been switching over their practice to virtual, or almost the majority of the practices to virtual. Telehealth has shown its value in this time of COVID through innovations to improve healthcare delivery, to decrease PPE usage, and decrease exposure for both patients and providers within the hospitals. You are using telehealth to step outside of the bricks and mortar emergency departments to care for your patients. And you're also bringing telehealth within the emergency department. We all need to consciously create systems and communications to share these innovations and lessons learned across this country. During this presentation, you will hear from a keynote presenter, Dr. Judd Hollander, and then followed by 4 panels. If you look at the panels here, just quick description, panels 1 through 3 are going to be panels discussing innovations in telehealth and emergency medicine, with panel 4 discussing the regulatory changes that we're all striving to keep up with. The planning committee did initially think about naming panels 1, 2, and 3 for pre-emergency department, then within emergency department, and that third panel post-emergency department or post-discharge. But then we realized that these lines are starting to become blurred from these innovations in telehealth. So we decided to keep the names as they are right now. Today's presentation is brought to you by the Consensus Conference Planning Group, which today would have been the day we would have had our in-person consensus conference in Denver. However, we have now rescheduled this conference to September 22nd, 2020. We know that you will save this date and help us build a research agenda around the topic of telehealth and emergency medicine. I want to recognize several other emergency medicine and telehealth experts that are joining us online behind the scenes to answer questions throughout the presentation. Thank you, everybody, and your contributions in advance are greatly, greatly appreciated. And then for those of you joining us live, you may submit your questions for the presenters by clicking the Q&A button on your Zoom menu. Questions that are upvoted will be prioritized during our questions and answer session during each panel discussion. Any comments deemed inappropriate or any advertising will be removed. Okay, to kick things off, I'd like to introduce our keynote presenter for the afternoon, Dr. Judd Hollander, Senior Vice President of Healthcare Delivery Innovation at Thomas Jefferson University and the Dean for Strategic Health Initiatives at Sidney Kimmel Medical College at Thomas Jefferson University. Dr. Hollander is a professor and vice chair of finance and healthcare enterprises in the Department of Emergency Medicine, where his responsibilities include the JeffConnect Telemedicine program. His research interests include innovative care delivery models, including telehealth, cardiovascular disease, and wound management. Dr. Hollander has had over 550 peer-reviewed articles, book chapters, and editorials on these and other topics. Dr. Hollander is a past president of the Society, and he also was awarded the 2003 SAEM Hal Jane Academic Excellence Award and the 2011 SAEM Leadership Award. He's an amazing speaker, and you will love listening to him. So welcome, Dr. Hollander, and thank you for being here. I'm now going to turn this over to you to give our keynote presentation. And I think, Dr. Hollander, you may be on mute right now.
There you go. You're talking about telehealth and I already screwed it up. So anyway, I was thanking you, Emily, and thanking the Society. And I guess it's kind of an honor to be the first virtual speaker, although it'd be a lot more fun to go out with all of you and have drinks tonight. Today, we're going to discuss about emergency medicine and telemedicine and how we are, quote, virtually perfect together. Next slide, please. So this is the obvious stuff that I think is really easy to understand, but still needs to be said. If you didn't have a telemedicine program before COVID, you couldn't scale one up rapidly overnight. And this is the kind of item we've been talking about on a national level for some period of time, because everybody said telemedicine's great in a disaster, but nobody wanted to fund a telemedicine program before the disaster. That issue's gone away, but people who didn't have a program, little difficult to scale it up overnight. We as emergency physicians are in the ideal position to run telemedicine programs. Our day-to-day job is to tolerate uncertainty and often make decisions with far from complete data sets. We do this all the time. Telemedicine is relatively new for many people. We can't answer every question we would want to know, and it fits into our comfort zone more than some other specialties. But we're here today on behalf of SAEM, which is an academic society. So rather than just talk about program development, which is a large part of my life now, it's also important that we research the impact of the programs and train the next generation. Next slide, please. This slide summarizes our JeffConnect program pre-COVID. And in a couple seconds, I'm going to tell you how we expanded this to deal with COVID, really more or less overnight. If you look at the inner gray circle, patients are at their baseline. And the first thing that happens when they fall off their baseline, whether or not they have multiple chronic medical problems, or they're a previously perfectly healthy 20-year-old, is they get a little sick. If they don't get better, they get more sick. If they continue to get sick, they show up in our emergency department. And it's not coincidental that that's where the clock strikes 12. About a quarter of patients in your ED get admitted to an acute care phase. Your hospital does really well with them. About 99% or more go home and go through a post-acute care phase and then return to their baseline. A lot of federal programs have been focused on decreasing reimbursement, focusing on the post-acute care phase. At Jefferson, we focus not just on the right side of the wheel, but also the left side of this wheel, with the premise being the best way to save a readmission is to save the first admission. And we've grown out the programs around the outside, and I'll start at 12 o'clock. We have a tele-intake program where when you come into the emergency department pre-COVID, you were seen remotely, kind of like a physician in triage program, which was our precursor to it. But then we realized we could have one physician in triage seeing patients at 2 hospitals. So you rolled through the door, you're seen remotely. The doctor who saw you would write a note on you, write orders on you. You would basically go from the triage area to get your chest x-ray, your labs, and then wait for your room if the rooms were filled. So by the time you were seen, your care was expedited. We started out with physicians. We changed that to advanced practice providers. We decreased our left without being seen from about 5 to 1%, and our door-to-doc time's about 9 minutes. At 1 o'clock, we have a critical care network, which is largely focused on neurostroke. Our neurologists and neurosurgeons are in 38 hospitals providing care and have a mobile ambulance unit. I'm not going to discuss that more. We had a virtual rounds program. The whole premise was when you're seeing a patient and their family's not there, we can just bring the family into the room virtually, engage them in the care. From 4 to 7 o'clock, less emergency medicine involvement, but was our post-discharge program. And we had about 1,000 doctors doing scheduled visits across the enterprise. Every specialty you could name, they were trained, they did some visits. But like everything else, there's early adopters, people who play nice in the pond, but aren't really into it, and then people who lag behind. At 9 o'clock was our direct-to-consumer JeffConnect on-demand program that Dr. Joshi, who's part of this conference, runs. She's the medical director. This is where anybody, public or people with contracts, could call in, see an emergency physician 24/7, 365, and we would take care of you. And then we have this entity called the Virtual Emergency Department, which is that JeffConnect app on steroids, where we can coordinate testing as well. Before we talk, next slide. So before we talk about what we did with this, I want to talk about, from the research perspective, how we measure success. We take the telehealth measure framework from National Quality Forum, which breaks things down into these 4 domains: access to care, financial impact and cost, experience, and effectiveness. And everything we measure to look at success fits into this NQF measure framework. Next slide. And then I want to give you our overriding philosophy, because in order to scale a program, you have to know where you're coming from and where you're going to, and what are your general beliefs. First, we don't believe telehealth is about the technology. It's much more about the workflow and operations. And telemedicine is just a care delivery model. It's no better a tool to take care of a patient than a stethoscope or an ultrasound is. It's just a tool you use some of the time for some of the people. It's not a manner of care. The medicine is the same. If you have sepsis, you treat sepsis the same way, your outcome for sepsis is the same. We don't like to think the appropriate comparator is an in-person visit. It's the alternative, which for many patients is nothing. And we have to get people over the concept that you're not doing a physical exam. You are doing a physical exam. And in an academic medical society, you have all stood in the doorway and watched the resident examine someone and looked at a patient and been able to identify sick or not sick. Additionally, you get more information than you might get in an office or an emergency department visit, because you get to see the patient in their home. So if it's asthma and there's dust all over the place, steroids may be a great short-term intervention, but it's not going to solve the problem. And finally, in the setting of COVID, really, really critical for people that have telemedicine programs, when the feds relaxed guidance and promised the OIG wouldn't prosecute you for ignoring security measures that are normally important to enforce, don't sacrifice your long-term strategy for short-term gain. Next slide. This is how we took the wheel I described to you and invented what we needed for COVID. So at 9 o'clock, our on-demand platform already existed. We just saw both COVID and non-COVID patients, right? Because there's sick COVID patients, worried COVID patients, but in some segments of America, it's the people who are getting left behind that don't have COVID that have been unable to get care. We provided care for both. We then took that model and integrated it into our COVID screening and testing. So not only were we seeing the non-COVID patients, we were seeing patients with COVID, and we made that the funnel for our whole enterprise. So you call JeffConnect on demand, and if you warranted testing or warranted isolation or home quarantine before we were testing, we gave you the instructions to do that, and then we closed the loop so we could get you your test results back. In tele-intake, we use that model to do forward triage and move that to the front of the emergency department and even outside to the tents, so people could be seen, and if they could be redirected to care elsewhere, they could be caught up front and kept out of the emergency department safely. We did this entity called interprofessional collaboration that we've never before done in emergency medicine, and we had to have it approved by all of our medical executive committees. This is the formal drive-by. It is approved by CMS. It is basically, you can do a consult or ask for a consult. The consult writes a note, but they never do face-to-face care for the patient, and it's billable by the consult, but residents can't be involved. So it's a little bit of a blessing for speed because it's an attending only thing. So imagine you see somebody, as an example, with a seizure that is on a therapeutic dose of whatever they're on, and you want to know what to add next. That consult will look in the chart, review their records, write a note, never see the patient, and you can move on following their recommendations to the next patient. It's a formal CMS measure. Then we created, taking our virtual rounds program, an inpatient telemedicine platform, which we didn't have before. We actually took Zoom, we put iPads in every COVID positive patient room, in every PUI patient's room, created a dashboard so I could actually go, click on the hospital, the floor, the room, and I, doing a virtual consult into the room, can maintain expertise even if we had workforce shortages in some specialties. And we leveraged that so patients' families could do the same thing from home. And finally, our scheduled visit platform was the main way we took care of non-COVID patients. And I'll show you some cool data on the next slide. So these are our volume increases. Our on-demand program literally went up 20-fold overnight, and we had to find new people to staff it. We made modules, we trained people online, and Dr. Joshi trained people in person. And the first day, we had a 20-minute, 30-minute wait to get on. Most of the days afterwards, nobody waited more than 5 to 10 minutes ever. This is one segment of Jefferson's population in New Jersey. This is a primary care practice. You could see the blue is their goal for the month. The orange is their monthly metric. You could see they did 100, 120, 125 through February, then 6,095 visits in March. And we actually became COVID positive in our region in mid-March, even higher in April. So tremendous scale. What we did for staffing is we took the practices that weren't seeing a lot of in-person visits, let them help us with on-demand, and we were able to leverage our quarantine physicians because they could stay home and do telemedicine. But really, training and quality control were the big issues to stay on top of. Next slide. This is my favorite slide. This is the Department of Medicine. And you could see in blue is their in-person visits. And you could see they weren't large telehealth adopters with very little red until middle of March. And by the end of March, early April, 90% of their visits were being done by telehealth. Overall, we were able to maintain 65% of the visits that had been scheduled during this COVID crisis to date, but 90% of them were converted to telemedicine. So a nice way to take the people who weren't adopters and have them adopt really rapidly. And now we believe the world will be different afterwards. Next slide. So this is, I think, the way I like to summarize thinking about telehealth. Our obligation is to provide quality care. I think we can all agree that it does not matter whether the care is provided on the 3rd floor or 5th floor of a medical complex, is documented in Cerner or Epic, is performed by a physician who's wearing contact lenses or glasses, or whether the patient lives nearby or far away. Similarly, it should not matter whether that care is rendered via telemedicine or in person. Quality care is quality care. And that's what we strive to do. So reimbursement models should become more about quality and less about how we care for the patient. Whether I have contact lenses, glasses, or a video screen, it's my expertise the patient wants, and I can provide that. Next slide. So the federal guidelines that were relaxed have caused a lot of confusion. They mostly pertain to CMS, and really what they say is the OIG won't come after you if you violate HIPAA or violate the security or use a non-traditional telemedicine platform. But if you're not in the telemedicine game, what you may not understand is they don't overrule state sovereignty. And states determine whether a physician could practice in that state. States determine whether you need informed consent, i.e. terms of use, before you do your visit. States and commercial payers will determine whether you need audit trails and can document the visit happened. And the commercial payers and CMS will determine compliance with billing. So the fact that they said, go ahead, use FaceTime and use these non-traditional platforms might not be legal in the state where you're doing it. And even though the feds won't come after you, I learned this morning from my colleagues in Avera that Deanna's aware of several lawsuits that have come after people for using platforms without maintaining security. They haven't played out, but there is a risk with deviating from best clinical practices. And then the billing hassle for all of us is most commercial payers only have a short-term fix where they'll pay for it. They actually have dates like in June when billing will expire, and most of the on-demand platforms don't take patient payments through commercial payers. So whether or not these on-demand platforms can build it will determine on what's going to happen in the long term. So right now, many people are not in compliance with their payer contracts. So it's great that the feds did this to try and make it easier to get up and running, but there's confusion and fear that not everybody is aware of. And to my last slide, please. I do just want to point out, since this is SAEM and we're in the research and education game here, that we actually have a variety of training programs. We're not the only people that have them, but we have online training modules, online physical exam modules. We have programs for pre-health, pre-admission students, med students, residents. We have our 4th fellow entering in a 1-year fellowship program. We have an Institute for Digital Health and a Telehealth boot camp. And these are the kind of things that you, as members of SAEM, when you're growing out a telehealth program, should look to do, because we're not doing the best we could do if we're not studying what we're doing and we're not training the next generation of students how to do it. And with that, I will stop. Thank you so much for your time today, and enjoy the rest of the day. It's a great program.
Great. Thank you so much, Dr. Hollander. As always, always wise and great. And I'm really impressed that you 90% of those visits turned over to virtual, from especially those that didn't want to really do it before COVID. So it's amazing. And you built this up well for people sticking around to the last panel with the regulatory panel. So, all right. So as noted on the screen here, there are a couple of questions for you in the Q&A box. So if Dr. Hollander, you want to jump on to type out some of your answers to those questions, it'd be great. And then we are going to turn to our first panel of the day. And so this first panel is on the topic of community paramedicine and pre-hospital care. And so what does pre-hospital include? For this one, it's not just EMS. This also includes, in that telehealth world, virtual urgent cares, drive-through testing programs, and referral hotlines. So this panel will talk about telehealth innovations that impact care of patients prior to arriving, or sometimes even avoiding the emergency department. Dr. Nicholas Moore will moderate this panel. Dr. Moore is an associate professor of emergency medicine, anesthesia critical care, and epidemiology at the University of Iowa Carver College of Medicine, and an investigator in the Rural Telehealth Research Center. He has published studies on telehealth previously and has been funded by the Agency for Healthcare Research and Quality, the Federal Office of Rural Health Policy, and the Veterans Health Administration to study rural telehealth applications. Dr. Moore, thank you for agreeing to moderate today's panel. And as a reminder for those of you watching live, please send your questions via the Q&A pop-up by clicking on that Q&A menu bar. Thank you, and I will turn this over to you, Dr. Moore.
Thank you, Emily. I'm really excited to be with you today with four fantastic panelists to talk about community paramedicine and pre-hospital telehealth. Our first panelist will be Dr. Sam Shen. Dr. Shen is a clinical associate professor and vice chair of clinical operations and quality in the Department of Emergency Medicine at Stanford University. He's also the associate chief quality officer for Stanford Healthcare and directs the Emergency Medicine Administration Fellowship. His academic focus is in digital health, quality improvement, and patient safety. Our second presenter today will be Dr. Michael Gonzalez. Dr. Gonzalez is an associate medical director for the City of Houston Fire Department and EMS Division. He's also on the faculty at Baylor College of Medicine in the Emergency Medicine Residency Program. Dr. Gonzalez is the director of ETHAN, which is the Emergency Telehealth and Navigation Project. And he's a veteran of the United States Air Force with multiple tours of duty, providing emergency medical care and transport. Dr. Gonzalez has an academic focus of pre-hospital airway management, telemedicine, and critical care transport. Dr. Aditi Joshi will be joining us today from Thomas Jefferson University. She's an assistant professor of emergency medicine at Thomas Jefferson University and also the medical director of JeffConnect, Thomas Jefferson University's telehealth program. Dr. Joshi is the director of the Telehealth Fellowship at Thomas Jefferson, and she's also the chair-elect for ACEP's Telehealth Committee. And our fourth presenter today will be Dr. Jonathan Berkowitz. Dr. Berkowitz is the medical director for Northwell Centralized Transfer Center in New York City and Northwell's EMS agency, CEMS. He's a board-certified emergency medical services physician, and he focuses on advancing transfer systems of care, healthcare command centers, and expanded scope of pre-hospital care. Our format for the panel today will be that each of the presenters will give a short presentation, and then we'll have about 25 minutes at the end for them to field questions. So feel free to use the Q&A box to put questions in, and we'll field those during the second session of the panel. So we'll get started with Dr. Shen.
Thank you very much. Thank you for the introduction. Next slide, please. I'd like to take this opportunity to talk about our emergency department drive-through model. And I'll start at the beginning, early March, when we were fortunate where our Department of Pathology developed an in-house RT-PCR COVID test. And so this was the March 3rd, March 4th. So we anticipated that the volume of patients coming in to get tested was going to rise dramatically. We were also concerned about PPE, personal protective equipment conservation, as well as preparing for surges. And so with that, we looked to the ED drive-through model. Like many EDs, the physical footprint is always a limiting space, as well as number of negative pressure room. So at a high level, we designed a process that has been done potentially in many other places in other countries, but this is our version, our take on it. There's a screening process, a registration, RN assessment, a physician televisit, followed by a swab and discharge. So at the screening process, we station a nurse outside of the ED, where in full protective equipment, they would ask questions about pulse, heart rate, and fever temperature check, as well as screening questions related to symptoms. And we've adapted the screening criteria over time as the CDC guidelines have changed. Once that person screens positive, and again, this is very, very quick, that patient would then text a photo of the driver's license to the registration folks that's already in the garage, anticipating and waiting for this patient. And by the time the patient drives to the drive-through area, the registration can already pre-register based on that driver's license. In the garage adjacent to our emergency department, we set up 2 lanes that can hold up to 6 vehicles each, and with a team that can go back and forth between the vehicles. This team comprised of a nurse as well as a tech, and registration is also not far behind. In full PPE, the nurse would then ask, again, confirm the screening questions, do part of the initial intake, and if they screen positive, they would activate our standing orders for a COVID test. At that point, the physician who is in the main ED via a telemedicine cart will be pulled alongside the car where the patient's at the passenger side or the driver's side. The physician would do his or her assessment, confirm the assessment, and also then confirm the COVID test. They can also add some additional tests like the flu test or some other very basic swabs if necessary. But majority were just for COVID. Once this was done, the nurse would then do the swab. A pre-printed set of instructions would be provided to the patient, and the patient would then be discharged from the system. Altogether, this process took on average about 28 minutes. And again, we really modeled it after, as you notice, that picture of that NASCAR pit crew where we wanted to bring all the services directly to the patient as quickly and as efficiently as possible. Next slide, please. I'd just like to touch on some of the challenges that we faced as well as the benefits of such a model. Given that we were taking over the space in the garage next to our ED, we had to recreate that infrastructure to support that. So obviously a Wi-Fi connection was really important. Power to that area was important. So we got generators. We set up a hot zone, cold zone, hand washing stations, obviously mobile workstations for computer for our registration staff. We had to work with our IT to customize the EMR because we wanted a very quick template for the COVID notes. And we had to coordinate with security and parking and all the various ancillary support to make sure that the patients can flow through the system as quickly as possible. In the end, we realized a lot of benefits with this model that we felt was very scalable. First of all, first and foremost, we thought that the care was just as good as the patient came to the ED for COVID screening. But we were able to decrease the healthcare worker exposure because this truly was a no risk shift for the emergency physician. It also reduced the risk of transmission to other patients in the department. The fact that you only have to use a PPE, full PPE for the swabbing, you can just change the gloves. We worked with our infection control, really help support a conservation strategy for our PPE. And finally, as I mentioned, this was something that we could scale in anticipation for the surge. And this area became our area for, again, the low risk PUI patients. And so that was our approach to the ED drive-through model, which we found very beneficial for our system. And with that, I will turn it over to Dr. Gonzalez.
Thanks very much, Dr. Shen, and it's a pleasure to be with all of you. Thanks again to SAEM for hosting this. Next slide, please. So I want to introduce to you a model that some of you have heard a little bit about in the past, and that's ETHAN. As mentioned, Emergency Telehealth and Navigation is a project we started back in Houston back in 2014, really to address the growing concern that many of you face with increasing numbers of 911 calls for a variety of reasons, some of which seem to be care that is potentially avoidable or potentially addressable in a different setting other than the emergency department. In the city of Houston, fourth largest city in the country, we face somewhere around 500,000 calls for EMS transport, EMS calls for service a year, resulting in somewhere between 500 to 600, sometimes up pushing 700 EMS transports a day. Knowing the many budgetary concerns that most of our municipalities and communities face, many of you know that this simply isn't something that could continue. So we used new technology at the time, this was 2013 as we were building this program, to try and leverage and extend an emergency physician out to the scene. So as pictured, our program really doesn't begin until a 911 call has occurred. So Ethan really is a tool. It is a tool for our emergency responders, EMTs, paramedics, firefighters. It is not, I want to extend sort of the analogy and the metaphor that telemedicine is a very unique tool. It is just that, a tool. It is not the only tool. And what we learned very quickly is that Ethan is capable of handling a lot of different diverse situations, including COVID, which I'll get to shortly. But it is certainly not going to address every single possible problem you might have within a community response model. So 911 call goes out, our field response personnel go out, do an assessment. Based on their assessment, so this is absolutely not performed on every EMS activation. Based on the field crew's assessment, they make a determination as to whether or not they feel this patient may be appropriate for Ethan. If they think it is appropriate, they simply touch a single button, activate it on the tablet that you see there, and then you see myself or any one of the other 18 to 20 Ethan physicians we have pop up on the screen and get a very short report from our field units to give us an idea of what the situation might be. Much like Dr. Hollander mentioned, many of you have really been practicing and performing telemedicine, especially in an academic setting, before you've even really thought about how that model would work, because you're doing it from sort of the bedside with residents and other providers doing some of the more exam and initial survey sort of things at the initial scene. So really, as an extension, as Dr. Hollander mentioned, really the emergency physician is uniquely suited to this. So as the encounter proceeds, the Ethan physician, and it's all board certified emergency physician, then makes a quick determination about what's next, what's most appropriate for that patient. And there are a variety of scenarios. We can recommend simply at-home care. We can recommend an alternative clinic setting. We are working to scale up some of our urgent care response capability or urgent care aftercare capabilities here in the city of Houston. And then of course, there's the possibility of an emergency department visit. So because we're with an EMS response agency, and as I mentioned, one of the things that we were most critically faced with solving because of Ethan was really the idea of how do we more efficiently use our crews. What we also really wanted to do was try and limit the number of patients being transported. So the other alternative, and what has turned out to be the most common alternative, is that we can safely avoid an ambulance transport for a large percentage of our patients. Next slide, please. So what we've really done with Ethan over the past 5 years is we've treated more than 26,000 patients safely through Ethan. We've literally had 0 serious safety events related to Ethan, and we get very good patient feedback in terms of their experience. Most importantly, from a budgetary perspective, we really see that we can safely avoid an ambulance transport about 90% of the time with our patient encounters. And we know that we're saving significant time for our crews because most of the time the Ethan physician is really only on the screen with the patient for about 5 to 5.5 minutes based on our data. And we know that most of these patients are going to get safely transported either by cab, personal vehicle, friend, somebody else that might be able to do that. And we know that it gives significant efficiencies to our crews because they're not transporting these low acuity patients to our already busy emergency departments. And we found, based on the data collected, that we're saving each crew about 45 minutes of time to getting them back in service that much faster. So for COVID, And I couldn't agree more with Dr. Hollander's statement that quality care is quality care, no matter how it's provided. We really leveraged our existing structure to add the additional idea of a dedicated decision support tool for our Ethan physicians. We did have to partner with some of our different transportation providers to add safe transportation for patients that did in fact have some initial screening questions come up as positive in order to be able to transport them safely. And what we finally worked out were a couple of different specially outfitted cabs that are funded by the city where we could safely transport the patient to a hospital destination with a mask, either a divider, a mask for the patient, a mask for the driver, or a combination of all three. The biggest challenge we faced, and this has really recently come online, is that many of us in the US have faced problems with testing and the capacity to do testing in large volumes. So we were initially very happy to partner with our local health department to get directed testing opportunities where the Ethan physician could interact directly with the patient who called 911, sometimes because of a potential COVID exposure, and we could direct them away from an emergency department to a directed testing location. The other thing we've been very fortunate and are happy to highlight is a solution for some of our undomiciled or homeless population where they are often fall through the cracks of many of our solutions. And we work very closely with an organization here in Houston called Healthcare for the Homeless that really does provide not only testing options as well as a safe place to stay, particularly if they test positive. So I look forward to your questions. I very much appreciate the opportunity, and I look forward to, and I will hand it over now to Dr. Joshi.
Thank you all. Thank you for having me, and to SAEM for setting this up. Next slide, please. So I too am from Thomas Jefferson University in Philadelphia, and Dr. Hollander gave a great presentation of our various telehealth programs and interventions for COVID. I'm going to specifically speak about our on-demand program response as how we use it for outpatient testing and a pre-hospital intervention. So briefly, JeffConnect is both our platform name and the name of our on-demand acute care telemedicine, which we call On-Demand. It's traditionally staffed with EM faculty. It runs 24/7, 365. We'd had different iterations of how we staffed it. But pre-pandemic, it was essentially single coverage and no other clinical responsibilities aside from the overnight shift. So like everywhere else, when the COVID-19 pandemic started to happen, Jefferson did similar things with creating surge capacity, getting PPE, and creating screening and management protocols. What we also did is realize we could use those protocols and leverage our on-demand service, link it to outpatient testing sites, and be able to screen patients that way. Because we were local, we were able to geographically link to patients and feel that we could have a better intervention that way. We started seeing a spike in our volume about March 9th in our on-demand. We hypothesized, aside from the media coverage, there was public education, outreach, and also our on-site clinics and our urgent cares, if patients were not critically ill, were directing people, if they had questions about COVID, to call our telehealth program. Because of this, we saw about a 20-fold increase in our volumes. We also noted that the types of visits we were getting were not only COVID related, but there were also people who were just afraid to show up to a clinic due to exposure, and they wanted to know what they could do, and so they could have a medical encounter. Okay, next slide, please. So this increase in volume and the type of visits really informed our approach. And so two things happened simultaneously. So at the institution level, we created a bunch of outpatient testing sites. We covered Eastern Pennsylvania and Southern New Jersey. So we had a couple of different sites. They were either drive-through or walk-through, since one of them was in the center city of Philadelphia. To create a more streamlined approach when people showed up to the testing site, our Seamless Access group created basically an 800 number. So after an order was placed, patients would call that number. They would get registered into our EMR. They would ensure their demographics were correct. They would get directions to the testing sites, information about what to do when they got there. So this allowed patients, when they showed up at that testing site, just to get swabbed and then go right back home. For callbacks and results, we had a team dedicated who are made up of primary care physicians. They would call all patients back with negative or positive results, give them advice on what to do, reevaluate their symptoms, advice on when to go back to work and when to be seen for a higher level of care. On the telehealth side, and because I already had a team, right? We had an admin team, a staff, processes, QA, IT all set up, and 37 EM faculty already staffing it. This made it much easier to scale. We'd already also had training protocols, so we had to do two things. We had to up staff, and we also had to scale our training protocols. So we did it in a couple of ways. One, we recruited more of the EM faculty who are either high risk, who are quarantined, or had just not done it before, and we trained them just in case they were needed. We also recruited colleagues from internal medicine, family practice, anesthesia, and a number of APPs to get trained, so that over a 72-hour period, we trained about 150 new clinicians. Then we also streamlined our QA processes. The initial QA was much too bulky to figure out how to do this for the amount of people that we were using in different departments. So we streamlined this. We recruited medical students and research assistants to help with the chart review so we could do that. Next slide, please. So this shows some of our results. We considered our surge probably from that March 9th week until about last week. And we saw about over 6,500 patients on demand. We tested about 30% of them. However, many more of the complaints were about COVID specifically. Some of the things that we noticed we hadn't anticipated was we had an IT issue once because we didn't realize that when you add a number of physicians, it would overtax the system. So that got fixed fairly quickly. And again, I want to reiterate that because I had this program done and it was already set up, it was much easier to scale and get people on there. But one thing I want to stress too is having to streamline QA. Anyone who does QA probably realizes if you have people from different departments and you're trying to get them to do the same thing, it is much more overwhelming to do it. So streamlining that made it much easier. Currently, our volumes have come back a little bit lower. We are back to only EM faculty staffing, even though we've increased our hours because we are not back to our pre-COVID levels. Still, we've been able to see a lot of patients, probably decreasing our PPE and give people healthcare interventions when there weren't clinics open. And so we're very proud of that. Thank you all for your time. I look forward to any questions, and I'm going to be passing on the mic to Dr. Berkowitz.
Thank you, Dr. Joshi. It's a pleasure to be here and tell you about what we did at Northwell in using our command center, our emergency services command center, to help us manage the COVID pandemic in our region. So on our next slide, you see, on this slide, you see, so one of the issues that we had was we typically have been doing community paramedicine, telehealth, but we were asked by New York City to start taking calls from them and to screen those calls and to see if they don't need an ambulance response. And that was a unique thing that we hadn't been doing before. And it's very different than taking other types of telehealth calls. We utilized our existing infrastructure of EMD call takers who would then field the call, and then they would actually decide one of 8 different recommended care levels based on the EMD code, which is a system, there's thousands of codes based on the symptoms of the patient. And we found that to be very effective. Now, most of the institutions like ourselves found that there's a pretty high rate of a patient having severe symptoms needing an ambulance, roughly 40 to 50%. And that was definitely true for us. And being able to sort out those patients before we got on a doctor on the line was really important. And sometimes we'd also sort them to patients into a lower acuity group that could just have a scheduled appointment with someone else, because we really functioned kind of in the immediate on-demand model. On the next slide, I'm going to show you kind of what I think was one of the most interesting things we did, which some people might not even think of as telehealth, but I really do think is an important part. So we had a command center physician who's located in our center, and we had a couple of hospitals that were really located in the epicenter of the pandemic. And those hospitals were seeing tremendous volume, 3x volume for them than usual. Very sick patients, community hospitals that were having, intubating 5 to 6 patients an hour at times in their ER, things that are kind of unseen and unimaginable. And so what we did is we enacted a program where we would load balance those facilities and transfer out patients who we could. And we did this for over 800 patients, really from a couple of hospitals. And we had a problem of how do we figure out where those patients should go and ensure the communication was adequate, especially when the sending hospital was really taxed. So we used a bunch of technologies in innovative ways that we kind of rigged together at the time to create a process that allowed us to move at times 70 patients, and moving 50 patients a day was very easy for us. And it was actually amazing to me that towards the end, when we'd have a 30 or 40 patient day, that seemed like cake. And it was a very effective process. And the command center doc would go and review the charts of the patients. We would review their vent settings, their advanced directives, their oxygen requirements, their blood gases, and would then communicate with the receiving hospitals to figure out, to do that matching, because we really had to match the patient with the right facility. We were sending patients not just to tertiaries. Most of these patients went to community hospitals. So it was a very complicated process that our command physician doc really orchestrated. And they were doing that while they were doing telehealth. On the next slide, the other thing that I think was really important about utilizing our command center is that we had all this infrastructure that we could use. So like I said, these calls we were getting from FIDNY were, they were more complicated. These were sicker patients. So it was really great to have a 24/7 hotline that they can call back at any hour, and to know that there's a process that call would be taken, and that we wouldn't just turf it back to 911. And then we have nurses in our command center as well. So they had a process for calling back patients and seeing how they're doing. And these are things that we were easily able to build into our platform, and it really helped to be a big success for us in our region. So with that, that sums up. I look forward to answering any questions, and I'm going to hand it over back to Nick.
Great. Thank you, Dr. Berkowitz. We've had a lot of questions come through the chat, so we're excited to entertain some of those. For the next 20 minutes or so, we'll go through some of the questions. Let's start with Dr. Berkowitz. Obviously, you were rolling out your command center methodology during the middle of a pandemic. Can you talk a little bit about what you did to protect your team in the command center from COVID-19 infection?
Yeah, we were really afraid as we started to get more important in the healthcare system that just one case, especially with the quarantine requirements, could knock out our whole team. So very early on, we started a process where we had total access control, restricted access, mandatory screening at the door with a form and a process that was built. And then there was a mask mandate, and there were certain restrictions on how you would eat and convening and whatnot. And I'm happy to say it was very effective. I know other call centers that were not as successful at mitigating these risks, but for us, it was taking that into account was a lifesaver.
Great. The next question is for Dr. Gonzalez. Dr. Gonzalez, can you talk a little bit about, and this is a question from the audience, can you talk a little bit about the funding for your program? How did you fund the physician time? Were EMS agencies concerned about loss of revenue from not transporting patients? Maybe you can talk a little bit more broadly about that.
Sure, and I'm happy to follow this up later as well, because it's a little bit of a complex answer, but I appreciate the question. Dr. Moore. So Ethan initially started as part of the 1115 waiver funds, which was, again, way back in 2014. So it was federally funded as part of a grant program. We were very, very fortunate to get that funding so that really we were able to dedicate and craft a solution that was specifically for Houston, developed for the city of Houston, without worrying about the funding, which is obviously a huge concern for many of our programs. The 1115 waiver funding has obviously since expired, and so we've gone through a variety of different challenging situations to try and get sustainable funding, including some City of Houston funding, other municipal fundings, as well as some philanthropic funding as well. So we, in terms of the physician's time, they're paid a flat rate. Then we don't ever utilize a physician who is working in other areas clinically. They're really focused on specifically this project to try and make sure that our crews get a fast, timely response.
Great, thank you, Dr. Gonzalez. The next question is for Dr. Shen. Dr. Shen, talk a little bit about opportunities that you see now for other drive-up services in your emergency department. I know that a lot of emergency departments have been innovating in the period of COVID-19, but are there other services that you plan to deliver in this way after COVID passes?
Yeah, no, it definitely gave us an opportunity to kind of test out the drive-through process for surge, because what we found is that you can very efficiently process patients. So whether it's for COVID or just low acuity patients, we found that workflow meshes really well. So again, you take COVID out of it, still having a dedicated person remote in via telemedicine in an area that's separate from your ED to kind of conserve that precious real estate, we found is going to be something that we're going to look at for future surge planning scenarios.
Great. Dr. Joshi, this is a question from one of the members of the audience. Can you talk a little bit more about what you did for quality assurance that was different after you had trained up all of these providers from different departments, and how that differed from your kind of pre-surge operations?
Sure. So pre-COVID, our QA essentially was rate of referral to either emergency department or urgent care, antibiotic stewardship. We also looked at chart completion, how long it took to answer calls and how long the calls were. After COVID, for the streamlined process, we did a couple of different things. We looked at the number of COVID tests ordered, how many people went to the ED specifically. If they were employees, we were tracking if they were healthcare workers, and then also chart completion, especially because one of them were specific for patient instructions, like I had mentioned about getting them to the right outpatient testing site. Without that, they wouldn't have gotten the number and the information. So that was really important.
Great. Thank you. Maybe a follow-up question that has to do with quality assurance for Dr. Gonzalez. You reported that you hadn't had any serious adverse events. Maybe you can talk a little bit about what proportion of your total calls used the Ethan system, and then how you tracked those non-transports to be sure that there weren't any adverse events.
Definitely. So one of the statistics that I realized looking over my notes I didn't get to was that normally we based on several public health reports on the city of Houston specifically, it's been estimated, and this is probably true for a lot of other large cities, that somewhere around 20% of EMS calls can be classified into the potentially avoidable or primary care related visits to the emergency department. So really our aim with Ethan was to handle somewhere in the neighborhood of half of those concerns. So we really started with a target to hit about 10% of the volume to see if that would significantly impact our operational efficiency in terms of other metrics like scene time, and other things like that. So we've certainly been very successful with those things. We know that the ED diversion is certainly not the only important measure. So we try to really navigate our patients towards other clinics. As I mentioned, urgent cares are coming online lately. And I'm sorry, Dr. Moore, what was the second part of that question? I apologize.
Yeah, the second part of the question was just how you knew that there weren't adverse events.
Excellent question. Yeah, sorry about that. So we have a very close relationship, and in fact, part of Ethan really depends on a very close relationship with our regional health information exchange. So we do a quick filter through pretty much monthly to go back and look at any deaths, repeat 911 calls, and ICU level admissions. And we track those on a regular basis. And we've been very, very fortunate that, and we think that's obviously partly the first step, as I mentioned, is our crews identifying the patients who are appropriate for Ethan. Secondarily, the physician is there to make an ultimate disposition decision. And so we've been very lucky and really track that data very carefully.
Great, thank you. Great answer. Dr. Shen, a lot of questions coming through the Q&A about your drive-up services. Can you talk a little bit more about how patients end up in that lane of the highway? Are these patients who were coming for evaluation in the emergency department? Are they calling a nurse line? Are you advertising this through mass media? And that's how people end up in one of those lanes that you were where you were treating people. Maybe you can tell us just a little bit more about how people end up through your program.
Yeah, good question. I mean, we actually intentionally did not want to advertise it because we just felt that the emergency department, should not be the primary point for just routine testing. But we had to put something up because the rest of our healthcare system at Stanford, they were just trying to ramp up the ambulatory sites. So eventually, Stanford did put up 7 ambulatory sites to do the low acuity testing. But we were the first to put something up, so we knew that we would get most of the volume. We stationed a nurse pretty proximal to the entrance to the ED. So in theory, that nurse would have captured anybody coming onto our campus within, 200 yards or so of being seen as a potential patient. So that nurse dedicated out there, again, in full PPE, is doing a very quick, simple screen, just do they look sick, yes or no, and some basic questions. And if so, then they would be diverted into our drive-through process that is, again, near our front entrance, but adjacent, so that there was a path of travel to the area that we set aside in the parking garage. And so as we continue to scale this, we partner with our ambulatory and our primary care colleagues so that they could, again, do the bulk of the routine low acuity testing. But certainly even as they ramped up, we still were doing some because people would show up and, they're low acuity, there's no need to use a negative pressure room. So that's how we approached it.
Great. Dr. Joshi, you talked about how you were training up providers, and some of those providers, I believe you had said, were anesthesiologists and other specialties outside emergency medicine. Can you talk a little bit about how you trained up those providers? What was your use of kind of standardized protocols, and what the training process itself looked like?
Sure. So, yeah, sure. Great question. So we had training already, but it was done much smaller because it was really only EM faculty who were doing it. So what we did is created a webinar that went very slowly, step by step, what you would need to do in the EMR and the platform to go for a visit from A to Z. We created it so everyone could have access to it. So everybody, all the 150 people I'm talking about, could do that. We then set up Zoom sessions so they could go through it and make sure that they did that. And that wasn't just me, my telehealth fellow also helped with that. So we could just make sure that they understood that process. And then again, we did a QA, especially on their first few shifts. We would just look through their charts, make sure they understood it. And we're just on call for them at all times so they could ask and answer, and we could answer any of their questions. It was interesting, right, to work with them, especially with family practice and internal medicine. We ended up staffing 150 total clinicians in this way, but we actually never needed anesthesia or the APPs to staff in because IM and family practice took care of most of it. And it was what was interesting is that they do everything just a little bit differently. So for example, I found out they're much better at outpatient testing. It seems obvious, but it was easier for them to figure out some of the problems that we had because they knew the answers since they knew those protocols. So that was helpful for me too, to be able to understand so I could give better feedback to the EM faculty as well.
Yeah, it's great. Maybe just a follow-up question to one of the things that you were just talking about. I know that during your presentation, you were talking about follow-up testing. Talk a little bit more about how you got those people in for testing, where that was done, and how you reliably tracked those results to feedback.
So what we would do, once we screened them and they were deemed that they should get testing, we changed our screening protocols a few times just based on CDC guidelines, just like everyone else. So once they were deemed to be needing testing, we would put the order in Epic, which is our EMR. It would go through into the system, and then the patient would call that number that I mentioned, seamless access, because they could see that order, and then they would register them, make sure they got the demographics, and they would give them information about how to get to the testing site. The patient would go. They would already be, all of the people at the testing site had a tablet or a phone where the patient's name would show up. They would get tested and then go right home. And so then we had the group of people. So again, they would put that in there because they had access to the EMR that way, tell them, link it to the testing swab. And then they would send out the swabs a few times a day or once a day, depending on when it was in this process. And then they would all get linked into the EMR again. And that team, it was an informaticist from IM actually that created this with a team that was able to set up this entire group into various brackets. And so it would be positive or negative. Positive results would be called by one group of docs and negative by a different group. And that's how we made sure that nobody got lost. It made it much easier because if one group was in charge of all of this, I for sure think that something would have gone wrong. This made it much easier. So everyone had their one specific thing that they had to get done.
That's great. What a fascinating program. The next question is for Dr. Shen. Dr. Shen, can you talk a little bit about faculty response? What concerns did your faculty raise through your drive-up programs and through their involvement, and how did you address some of those concerns?
Yeah, I mean, there's always a little bit of a concern because it's new for us. We're still early in our digital health journey. And so, we were concerned that the response could be, well, you're not going to be able to get us good information, or it's not a real exam. But fortunately, it didn't pan out. And interestingly, as we thought about healthcare exposure, healthcare worker exposure, and PPE and risk, and that we had some high risk providers, it actually meshed really well because we were essentially able to say that this is a zero risk shift. And what we did is we had created different zones. We had a zero risk, low risk, and high risk zones that match to the exposure level and the comfort level. And so by doing this, I think it resonated well that for the high risk providers, this is an opportunity to see patients in that type of a low risk environment. So overall, it was well received.
Yeah, that's great. What a wonderful program. Can you talk a little bit about documentation in your program, Dr. Shen? How were you documenting those visits? Did it differ, or did that just look like a regular in-person visit?
You still needed obviously to document a medical screening exam. So at the very minimum, you need to demonstrate that. But fortunately, our Epic medical informatics director worked very closely with us to create just a very abbreviated note. Because again, we just want to prioritize speed. And so the note was just a very condensed version of our even quicker than a fast track note. And so again, it just captures the very basic evidence, a lot of prescribed wording that you can pretty much just accept, because again, majority of these patients kind of fit the same profile, so again, it was just a much more efficient way of documentation.
Great, thank you. Dr. Berkowitz, a lot of interest also in the questions about the command center. Can you talk a little bit about scheduling for the emergency medicine providers? I gather from your presentation that the providers who were doing this work were not on clinical shifts, but how did you incorporate this workflow into their traditional clinical schedules?
Right. So a lot of the physicians who were using for this were physicians who were actually were not working clinically at that point in time. So we adopted some physicians, while some of the physicians who typically do a lot of the work were more clinical. So there's a lot of agility that was required by our team to make it work, and that's actually one of the hardest things we had to do. We had to retrain new protocols on almost at least every other day, if not every day. Including for the physicians and for our team, and to make it work. We had 24/7 coverage, but we built a system, a way that they can do some of the work from home, and then some of the shifts were required to be there. But we would do a different scheduling format on a weekly basis.
Great. Maybe a little bit of a follow-up question on that. Were nursing homes involved in any of that load balancing that you were doing? I know that you're talking primarily about acute care beds, but I think that a lot of communities have struggled a little bit with COVID-19 in nursing homes. Was that part of your solution, or is that something that was completely outside?
So there was some involvement in that, but to be frank, the post-acute part of the organization was managing some of that so well. I mean, in terms of opening up their own spaces for those patients, for discharge patients, that I think that was less of an issue. The biggest concern were the requirements for when a patient could go back to a nursing home, and patients who came from a nursing home, we were then finding we couldn't get back to that nursing home. That was troubling, but the post-acute team did a phenomenal job. We did make some arrangements with some nursing homes to provide some services, or actually really assisted living facilities who were using us as a telehealth provider. But the discharge issue was managed really by the post-acute group.
Great, thank you. Dr. Gonzalez, back to Ethan. Can you talk a little bit, I know that we've talked with some of the other programs about documentation. Can you talk a little bit about how documentation is done for the Ethan visits? Is that integrated into a hospital's medical record? Is that strictly on the EMS side? How exactly did you and your team?
Yeah, it's strictly on the EMS side. It lives within an adjacent, I'll call it, record within the EMS medical record. So the way the process actually works is the crews, again, will identify the appropriate patient, and if they feel like it's appropriate, will send an abbreviated record actually to the physician on duty. That physician can then pull it up quickly, review vital signs, past medical history, location, any relevant information that is put, even before the call is generated. And so at the time of the call, that's why the call itself can be done in such an abbreviated fashion, is that we have essentially a lot of the information we need, especially to try and disposition the patient appropriately. Because using a portal that we developed here, we can identify the closest clinic, the closest emergency department, and even get a cab, if that's the appropriate disposition, dispatched while we're still talking to the patient and collecting information. Everything is recorded in an EMR that is, again, part of the EMS agency.
Great, great. Dr. Joshi, a lot of the programs that we've heard rely on grant funding to be sustainable. Can you talk a little bit, not specifically about the profitability of your program, but the sustainability as you have grown JeffConnect and how the increased utilization with COVID might affect that?
Well, I think in general, we have invested in it from a top-down approach. So I think it's a little bit different for us. We weren't doing it in the same manner, right? It was someone taking a chance on it years ago. So this is why we have it. And yes, for a while, it probably, we staffed it one-to-one. Our EM faculty were doing these shifts. It wasn't always, they would get full clinical hours for it. They do now because of the volume. So I think that to answer your question, we'll probably see a change now, but I can't tell you that it was profitable before.
Okay, great. Maybe a follow-up question about your patient population. And I think we're down to maybe the last 2 minutes here, but can you talk a little bit about, this is a question from the audience, about patients who are older and their ability to interface with your system, especially some of the patient groups that may be at the most high-risk groups related to COVID-19 infections, and their ability to use the JeffConnect platform?
So we definitely have elderly patients. And so I think I answered it in here too, but I'll just reiterate. So for our scheduled visits, we actually would have a team call them, make sure they could set it up so they could get into their visits. We have had patients who've had their family members or friends help them set up the app and get on the website. I certainly see a lot of elderly patients. I don't think it's been a barrier so far that I can tell you, at least anecdotally. I don't have the number, how much of the percentage of our patients are technically elderly. I think that it's somewhat of a myth that this population would not use technology. Maybe they need help just figuring out how to set it up and getting to the right place, potentially. But I don't think that they seem to be closed off to using it, at least the patients that I've seen. And I was just telling a funny story about a patient who was in this age group, just wanted to set up a visit just to see if he could do it because he was by himself, and he set it up successfully, had a visit, had no complaints, just wanted to know that he could do it in case he got sick and needed to have a healthcare encounter. So I think it's possible.
Great. In the last 30 seconds, Dr. Berkowitz, one of the things that you raised was how quickly medicine has been evolving in the era of COVID and how that required retraining of your teams almost daily. Can you talk a little bit about the process that you used for keeping your team up to date? I think that every healthcare system has been challenged by this in the last few months.
Yeah, I mean, I don't think there's great solutions for this, to be honest with you. But first of all, we ended up limiting some of our team. So we generally like to have, we kind of abhor specialization. So we like everyone to be able to do everything. But we ended up creating special teams so we could limit that. And then on top of that, there's a lot of handholding and a lot of calls to folks on the admin side or who understood the program better, and making it clear. On the EMS side, for our EMD, our call takers, it was really important for them to be, because EMS call taking is very structured, and so this was a lot more unstructured. So it was really important for our team to understand that we're being agile and we're pivoting, and to embrace that, and not to be afraid of that. And if you have questions, to always ask. But not to go in, not to come from a kind of a discipline mentality where there's going to be some sort of protocol violation, but really that we are trying to pivot every day to what the needs of the healthcare system is.
Great. Well, I want to thank all of our panelists. We have a number of questions that we weren't able to address during the panel time. Those we'll come back and try to address in the question and answer box. So if you asked a question that we weren't able to get to, please pay attention there. I'd like to introduce Dr. Megan Rainey, who will be joining us to moderate the next panel.
And I'm actually, Dr. Hayden, I'm going to jump in here just real quickly just to set up the panel. I just want to let people know there's been quite a few really amazing questions for those that are on Zoom right now. Just so people know that these questions will be transcribed and be available on the SAEM website after this. excuse me, and then also the recording of this. I mean, I think I was just amazed with this last panel. There were so many nuggets and pearls from the different speakers there on several different topics on the pre-hospital space. So know that this whole conference is being recorded and will be will be available on the SAEM website. So our next panel, panel 2, will be on the topic of telehealth use within the physical emergency department and urgent care. So if you just heard Dr. Joshi was talking about the virtual urgent care in the panel 1, panel 2 is when we actually take telehealth into the ED or the urgent care. So as you know, prior to COVID, telehealth has been brought into the emergency department with specialties and subspecialty care such as telemental health, telestroke. Tele-emergency medicine also has existed for over 2 decades, and that's been bringing emergency medicine guidance to those sites in rural or critical access hospitals. There also has been this teletriage function that's been operating within emergency departments, allowing physicians to be able to see patients at triage via a tablet, start diagnostic and therapeutic workups, potentially remotely or potentially from another ED within the same ED system. So today, this panel is actually going to talk to you about the new uses of telehealth within the emergency department. And so some of these that are going to be helping decrease the PPE usage, and then also some of these of providing support to all of us that are struggling to get through this COVID pandemic in the clinical world. So the wonderful person that gets to moderate this is Dr. Megan Ranney, as you see her up on the screen on the slide there. Dr. Ranney is an associate professor in the Department of Emergency Medicine at Rhode Island Hospital Alpert Medical School at Brown University. She focuses on the intersection between digital health, violence prevention, and public health. Dr. Ranney is a member of the SAEM Board of Directors and director and founder of the Brown Emergency Digital Health Innovation Program. She is Chief Research Officer for the American Foundation for Firearm Injury Reduction in Medicine and a founding member of getppe.org, dedicated to matching donors to healthcare systems in need for protective equipment. She's been a PI or co-I for over a dozen federally funded grants, all focused on technology-based interventions for high-risk populations. Thank you, Dr. Ranney, for agreeing to moderate this panel. And just as a reminder to the audience, please continue to use, for those live on Zoom, continue to use the Q&A box for your questions, and we will attempt to answer many of them live. And as you can tell, our content experts and panelists are furiously answering them too. So with that, Dr. Ranney, I'm going to hand this over to you now.
Thank you, Dr. Hayden. It's an absolute honor and delight to be here moderating this panel today. And again, a huge kudos to you and to the entire team for not just planning this important consensus conference, but also transitioning it so quickly into the virtual world as we made the decision to cancel this year's in-person SAEM annual meeting. I'm just really, really thankful for your ingenuity and work here. So thank you. So without further ado, I will introduce the panelists. We have 4 panelists today talking about telehealth use within the ED and urgent care. First is Dr. Erica Olson, who is an emergency physician and director of virtual health services for Columbia University's Department of Emergency Medicine, my alma mater. Her oversight includes telehealth endeavors at 4 emergency departments within the New York Presbyterian Hospital System, including the Morgan Stanley Children's Hospital of New York and Columbia University Medical Center. Her most recent focus has been on the development of telehealth responses to the COVID-19 crisis, both within her department and collaboratively across the New York Presbyterian Hospital enterprise. Dr. Olson is chair-elect for the SAEM Telehealth Interest Group, which you all should go and join, and is very excited to serve in this role during these burgeoning times in telehealth. And we're honored to have her today. Next will be Dr. Michael Ward, who is an emergency physician and associate professor at Vanderbilt University Medical Center and the Nashville VA. He's funded by the VA Office of Rural Health to develop the emergency telemental health and teleconsult service at the VA Tennessee Valley Healthcare System. Dr. Ward also co-developed the electronic PPE program at Vanderbilt University Medical Center Emergency Department. We're so excited to hear from him today. Our third is Dr. Kevin Curtis, who is the medical director of Dartmouth Hitchcock Connected Care and the Center for Telehealth, which was created in 2012, long predating COVID-19. The Dartmouth Telehealth currently has 8 telehealth services lines, tele-emergency and tele-ICU, both of which have 24/7 hubs, teleneurology, including stroke care, telepsychiatry, telepharmacy, inpatient telespecialty, outpatient virtual visits, and more. They operate in the very rural region of northern New England, where 50% of the hospitals are critical access. Many people are more than 2 hours from specialty care in the summer and may be impossible to access specialty care in the winter, and where the majority of the locations where they deliver telehealth services are not in the Dartmouth-Hitchcock health system. So he'll have some very interesting insights about how that works. Finally, Dr. Peter Greenwald is Director of Telemedicine for the Department of Emergency Medicine at New York Presbyterian Weill Cornell Medicine. He's been deeply involved in flexing telemedicine capabilities at Weill Cornell Medicine and at New York Presbyterian to meet the demands of the COVID-19 crisis. Some of his recent work in this area of telemed education is reflected by several abstracts and presentations at national meetings and publications in the peer-reviewed literature, which he'll be talking about today. So without further ado, we'll go to the first panelist, Dr. Olson. As with the other panel, each presenter will have approximately 4 minutes to go through their slides, and then we'll go through our Q&A. And we're looking forward to seeing questions from all of you appear as the presentations go on. Dr. Olson, take it away. Oh, Dr. Olson, we can't hear you. Are others able to hear Dr. Olson?
No, Dr. Randy, it's Dr. Hayden here. Maybe we can go on to
the next speaker.
And then we'll have to switch ahead a couple of slides, then we can try to get back to Dr. Olson.
Perfect. This is dealing in real time with the joys of telehealth, right? It's all about problem solving. So we'll go to Dr. Ward next. We'll come back to you, Erica.
That is definitely the beauty of emergency medicine and being able to adapt. Thank you, Dr. Hayden and Dr. Ranney, and to the program committee for including me in this as one of the members of the Telehealth Consensus Conference planning. I was sad to see that we weren't able to get this going for May, but excited to see it in the fall. I'm actually going to talk about one of the newer programs that we've developed. This is going to be 2 particular programs, both at the VA as well as Vanderbilt Medical Center. So next slide, please. We were actually funded by the Office of Rural Health within the VA to better understand potentially avoidable transfers. So actually working with Dr. Moore from the prior panel, we started examining potentially avoidable interfacility transfers within VA emergency departments. We found that mental health comprised approximately 1/3 of these, and reasoned that telehealth may be a way to potentially prevent these. So in 2019, we implemented a pilot program to conduct telemental health. And from there, we started to ramp up. However, we encountered a fairly substantial reluctance to adopt telemental health, particularly when there was a choice. And you'll see that this is a theme, particularly with the next project. But along came COVID-19. And we went from this reluctance to adopt to now not only being able to deliver telemental health within the emergency department, but now we scaled it to another site within the Tennessee Valley healthcare system within the VA, to then expanding this to the entire mental health service. So literally every consult within the VA at the Tennessee Valley was now conducted by telehealth. You can see on the right here, this was actually an adopted model that we used from Telestroke that was already being done within the VA using iPads and FaceTime to now take this existing technology and adapt it for telemental health. Next slide, please. In the prior panel, you heard about being able to protect providers and how telehealth could be used as a way to protect these providers. And working with Rob Turr, who you can see on the right here, we started thinking about how telehealth could be viewed as sort of a way to provide personal protective equipment, but in sort of an electronic format, what we call EPP, and wrote up this concept, and like most papers on COVID, was quickly accepted. What we ended up doing here was using telemedicine in a co-located fashion. So patients came on site and we were able to conduct the entire visit while at the same time satisfying the requirements for medical screening exams and EMTALA through these visits. But as a way to be able to protect providers, but at the same time giving them an option to be able to see the patients. So I'm at about my time, so I'm going to save the lessons learned, and we can talk about this more in the Q&A.
Do you want to, do you want to just really quickly do like 1 minute on the lessons learned, Michael?
Sure.
Go for it.
So really, there are 2 key points here. One is what I call sort of chance favoring the prepared implementation. Like Dr. Joshi and Dr. Hollander talked about previously, when you're ready and you've already been working on this and have a model in place, it's much easier to scale up rather than having to go de novo. The other piece is also playing nice in the sandbox, and I'm going to credit my daughter here with putting together this graphic for me. But there are multiple groups here, nurses, physicians, and health IT, that you all have to play nice in the sandbox with. Because ultimately, and we know this already in emergency medicine, that you can get much further doing so. So thank you. And I will send it over now to Dr. Kevin Curtis.
I'm going to have us try to go back to Dr. Olson. Let's see. Erica, do you want to try to see if we can hear you?
Dr. Rainey, it's Dr. Hayden again. I've been communicating with her. She's going to try to go last of these 4 panelists. She's going to try to jump on another device. So
no problem.
Well,
apologies then. Let's go to Dr. Curtis.
Great, thanks. Great to be with all of you. So as you heard a little bit in the intro, we've had tele-emergency at Dartmouth since well before the pandemic. And our model is similar to Avera eCare. It's a hub and spoke model with live interactive audiovisual. So we have a 4-station hub at our medical center, and we have dedicated connections to 11 hospitals in northern New England that are hardwired for the service. And just to take 30 more seconds for those who don't know much about it. Each of the spoke hospitals looks like what you see on the left of this slide. So 2 of their rooms are hardwired. They have a mic hanging down. They have a monitor and a camera up in the corner, and they have a button on the wall, and they can hit that button anytime they want any help of any kind, and it rings right into the hub, and we call them up. And in the hub, there is a doc and nurse available 24/7, 365, and that's their only clinical responsibility at the time. So everybody also works at the bedside, but those shifts are separate. And like I say, they can ask for whatever help you might ask if a doc and nurse walked in your own ED, and that can be, could you manage this case? I'm really busy. Second set of eyes or collaboration. A lot of them is nurse only. Just could you run and document this code? We think we got it covered from a medical standpoint. Could be for procedural assistance, could be for eyes on by a specialist, or it could be just, could you help me with transport and transfer and acceptance? Because at least pre-pandemic, for example, in our hospital, to get accepted here, it's often 45 minutes to a no. So if we can take that work off people's plate, that can be helpful. So in the face of that context, if we go to the next slide, please. Our innovations for COVID kind of fell into 2 buckets. One bucket that's talked about here is how could we make the current service even more acceptable to hospitals that want to join in? And this was important, but the less exciting innovation. which was really, we turned what is normally a 75 to up to 90-day implementation process and cut it down to about 20 days. And some of that was by taking advantage of things that happened independent of us during this current pandemic. So I've never seen privileging and credentialing happen so fast. And state licensure would have been fast. It turns out we were already licensed in all Northern New England states, but otherwise would have been quick. And what we eliminated was, as an aside, probably the most important thing in a successful teleemergency program is developing relationships with the bedside team and trusted relationships. And we normally spend a lot of time doing that in advance and once we go live. But we did eliminate a lot of those things, meaning kind of at the elbow go live support and our normal kickoff meeting with all providers and nurses and our mock calls. And so that allowed us to be much more accessible. What we'll need to keep an eye on is as things wind down or get the pandemic becomes more tolerable, do we need to do some regrouping on that relationship building to have the same interaction as normal? Next slide, please. The other bucket was what did we do new that we hadn't done before? And one of the things was we took the same hardware that we put in our spoke sites and we put it in all 8 of our negative pressure rooms in our academic medical center. And then we hooked up that to one of 3 places and you could pick the one you want. So we added a telehealth cart to the ED in a dedicated room. We connected it directly to the hub and we connected it to one of 5 tablets on stands that we deployed. And it was up to the local provider and nurses staff who they wanted to connect with. We envisioned that that would primarily be used for arrow number 3, a lot more medical screening exams by our team. And it was used for that, but what we actually found was it was much more frequently used for number 5, which were consultants on our cart or consultants from home or rounds from home, or number 4, rather than MSEs, the other end of the spectrum. So it was used very frequently for codes, resusces, and intubations where a much smaller group of people were in the room itself. The rest of the team was right outside the room. And here you see the nurse on the tablet that is connecting to the hardwired equipment. And with the nurse would maybe be the attending and an additional 3rd nurse, and they're doing documentation and they're talking live with the people right inside the room. And then finally, I'll just say number 6 is very recently that evolved into, we're building a couple of robots right now that will walk the tablets into patients' rooms with nobody having to go in the room to even further extend the preservation of PPE and decreasing exposure. So I'll look forward to questions about all of that. Thanks again. And I'll now hand over the mic to my colleague, Dr. Greenwald.
Thanks, Dr. Curtis. Quick sound check. All right, I see smiles. Love those robots. What I've found is it's hard to open the doors though. In any event, at Weill Cornell, before the world changing in March, we had a robust set of telemedicine processes, including a telemedicine teaching program through our Center for Virtual Care, a telemedicine urgent care for patients at home, similar to what you were hearing about from Jefferson, and a community teleparamedicine program that we were using to care for some of our sickest post-hospital discharge congestive heart failure patients at home, but using EM docs. And I'd love to talk about that program some other time. But within our ED, we also had a fairly robust set of telemedicine programs. In terms of numbers, our biggest numbers probably came from our Express Care service, which is a way we see low acuity patients by telemedicine using docs who we have doing telemedicine dedicated shifts. And we'd probably seen about 20,000 patients this way in total by the time COVID hit. In addition to that, we also have a variety of a provider and triage model where APP watches 3 separate hospital arrival areas, puts in orders for patients. And in addition, we had some other services that are probably familiar to many here, including emergency psychiatry consultations in our community hospitals, emergency stroke consults, an innovative program where we used remote pharmacy technicians to do medication evaluations and med reconciliation on patients. A remote nursing program that looks a little bit like a tele-ICU, but for the ED, and a fall prevention program where we watch all the patients in the ED using a technician who notifies care teams of behavior that's going to lead to a fall. The picture you see here is our Express Care program where my colleague, Dr. Halpern, is evaluating a minor wound. If we could go on to the next slide. This picture here is a picture of one of our physicians doing an intake examination in the triage area of one of our pediatric emergency departments. Next slide. So when COVID hit, like many of us have experienced, all our patients went away except for the sick ones. We were admitting 40% of the patients who arrived in the emergency department for almost 2 months straight. And at times, the majority of those patients were being admitted to the ICU. We had a dramatic need for ability to preserve personal protective equipment and to keep providing high quality care to patients who required frequent donning and doffing if you were going to go do a bedside exam. Which was not only hard on equipment, but put providers at risk that maybe wasn't necessary. And we helped make that not be necessary by moving all of these carts, plus purchasing a bunch of new ones, but familiar technology, putting it in patient rooms, not using those carts for the entire patient exam, but using them for part of the evaluation process. And I'll briefly describe that. The workflow we came to is an initial assessment where a provider did a bedside physical exam the same way we're all familiar with. But as part of that exam, did a sound check with the computer device in the patient room, familiarized the patient with the equipment, and then subsequent reevaluations, if they didn't require a repeat physical exam, or just updating patients on the progress of their care, could be done without entering the room again, and in a way that replicated a face-to-face interaction, but it was just face-to-face over the video. These devices didn't require any patient interaction to go live. They turned on remotely. So you could essentially walk into the room, and having familiarized the patient with the process beforehand made that less alarming. It wasn't only physicians using this equipment either. Nurses got a lot of use out of the equipment, and our social workers were actually big adopters of this technology. And we think what this did is really helped normalize the situation for patients, made them less isolated. If we're going to go on to lessons learned, I think we're not quite to the point that this technology is invisible. It still remains a little hands-on, getting the video to work properly, getting the sound to work properly. It's not exactly the plug and play easiness that we're familiar with consumer devices. They did have the great advantage that we already knew how to use them. For our providers who didn't know how to use them, we did a daily rounding with a train the trainer technique where we taught one provider, asked them to teach 2 others, put lots of sticky notes on computers with passwords and web pages that they had to go to, and found with that train the trainer process, in the matter of 3 or 4 days, we'd had almost complete penetration of our ED staff. And with that, I think I'll turn over to my good colleague, Dr. Olson.
Thank you. Can you hear me now?
We sure can.
Okay, thank you. Okay, take two. I'm really happy to be here this afternoon, and I'm enjoying listening to everything that everyone's done. As COVID started to unfold, we really experienced constraints within our emergency department. And since this section was about implementations within the department, I thought I would just kind of say that the constraints are what were our roadmap to our telehealth solutions. We knew we had this pre-existing technology, we had carts already in the department, and it was more a matter of coming together with our operations teams, even facilities, management people, and seeing what could happen. And so I grouped our constraints into 4 big categories: our staff, people going on quarantine, our PPE, which was a universal issue, space, trying to keep people out of the space and contain COVID in different spaces, and then the patient needs that were evolving rapidly. So today, though we made different solutions for all of these spheres, I'm happy to speak to them. Today, my focus is on the staff and what we did with those constraints. So we can go to the next slide, please. So this is a model called Nurse-Free Express Care. Actually, it's great that Peter just explained the Express Care model, which again is a low acuity model of care. We took it one step further and made it nurse-free, because what was happening, especially in the beginning of the COVID presentation, we were mobbed by large volumes of low acuity cough and cold type of patients, extremely nervous patients. The memo really hadn't gone out that people should stay home. It was really tough. And since we didn't even know that COVID was really in our midst before then, we actually had a significant number of staff have to go out on quarantine. Even if they didn't feel ill, we were, isolating and quarantining, and testing wasn't available. So it was a tough period of time. And we said, how are we going to survive without our nurses? Let's try to build something without our nurses. And so this is what we came up with. And so essentially, we built it in the emergency waiting room. And a patient would come in, and they would say they had cough and cold symptoms, and there was one intake nurse for the entire ED, so that nurse stayed there, but beyond that, no nurse involvement. And so they would just take the patient name, get them entered into the system, and then say, take a number, and then sit over there. And they were cohorted, patients with coughs and colds were cohorted in the waiting room. And then you can see an individual to the left of the picture. We called that person a circulator. And this was kind of an everything kind of role. We had many redeployed physicians at our disposal. We had attendings from other services, residents, fellows, the whole, all different kinds of medical professionals, including nurse practitioners, PAs. And so we could utilize any of them to fulfill this circulator role, where we would have a patient come get called in, sit down at a station, and then they would do vital signs and get a lung exam, and then securely text the virtual provider, who would just bounce between the different areas and see the patients. They took over the care from that point. They could write the chart, do the discharge. It went to the patient portal. If printed instructions were necessary, we could do that as well. And we also had piles of COVID information handouts. A large portion of the care at this point in time was education, reassurance, and giving resources for where patients could get testing. So it was a really nice way to siphon all of those patients off of just coming inside. And if anyone was requiring further care, then of course they just went inside. Okay, and then switching gears, we can go to the next slide. Another way that in which we helped our staff with telehealth, which was unexpected for me, was in mental health services. This was really hard. This still is hard. We are still in this, and our psychiatry colleagues made themselves available to us, not necessarily for traditional psychotherapy for us, but rather peer debriefments. They attended our department meetings. They kept things going in a productive direction. They also did a variety of things, like had drop-in lunches, lunch sessions for us, and it was interdisciplinary. So the residents could come, we could all just intermingle. It's been really exceptional and helpful. And so I just wanted to mention that it's a very simple use of telehealth. It's mostly video conferencing, but nonetheless, it's very powerful and appreciated. And I guess then at this point, I'll turn it back to Megan.
Thank you, Dr. Olson. And thank you for that beautiful presentation and for your flexibility. And also thank you for acknowledging Dr. Breen, who I know was your colleague. With that, I will go to some questions from the audience as well as from our fellow panelists. Let's see. I'm going to start with a question for Dr. Greenwald. You talked about your pre-COVID focus on undergraduate telemedicine education. So I wondered, how did you apply your experience with that to the ramp up for COVID-19 telehealth visits?
Oh, I think that's a talk in and of itself, but I'm glad to have a chance to try to answer. So our undergraduate education was primarily small group learning with focused debrief sessions and very much an in-person and individual by individual training process. That didn't translate too well into a situation where people weren't supposed to be in the same room if it could be avoided. So we took the same players that we have in our Center for Virtual Care doing that education and started making remote training videos. We widely disseminated a remote respiratory assessment exam throughout the enterprise. We also set up training modules that exist online that can get people through the basics. And we did an awful lot of one-on-one education. We made fairly broad use of that relaxation of HIPAA enforcement and would have a doc doing telemedicine workflows share screen with a seasoned provider and do education that way. Something we kind of cooked up on the fly that worked remarkably well. And I hope as the world enters the next phase of this and normalizes, if not a new normal, that we'll be able to continue to do that because, boy, it was useful.
That's awesome. We all look forward to learning more going forwards and applying it to our own training. Dr. Ward, I have a question for you. How has the ePPE been received by patients as well as by the other groups in the emergency department, like nurses and respiratory therapists? Obviously, all of us are still struggling with PPE needs and or anticipating resurgences of needs in the near future. So,
yeah, and thanks for that question. It's, you know, I think that there are several components to this. One is that you really have to be cognizant of, particularly in the age of COVID, of how you're working with others and whether or not you feel like you're sort of throwing them to the wolves. And so this was something we really had to be cognizant of as we're trying to protect ourselves. Are you potentially increasing the exposure for others? And so this was something that initially we didn't quite anticipate, but once we realized and we were starting to get feedback and why it's so important to have much more of a collaborative approach on this, we realized we had to adapt our process so that we were really trying to protect everybody that was involved. So it's really not just nurses, but it's the techs, it's even some of the physicians who are involved. And so getting input of those who are involved, but also recognizing when people don't feel comfortable, and in demonstrating that you're willing to also get in there as well.
Awesome, thank you. Dr. Curtis, a question for you. You mentioned, as did all of the panelists, that one of the most important aspects of a successful tele-emergency program is relationship building. Could you tell us a little more about that, how you handled it, any tips and tricks that you have for folks that are listening that are just getting started or who are facing these own challenges in their own shops?
Sure. So in our model, you're asking a local site to hit the button on their most stressful or difficult case of the day. And could you have a couple people come on a camera up in the corner that you only know a little bit and watch what you're doing? So kind of sounds like a challenging recipe, and it would just be easier not to ask for help. And so if you haven't spent the time in advance to really get to know the team and let them know that you're all on the same team, and really it is like you're walking in the room, that it's unlikely that you're going to be able to provide the help you want. And so we normally do a couple things to achieve that, some of which I described on the slide, is meeting a lot in advance. A couple other quick things are, one is over the whatever number of years or 2,000 calls, whatever, it is critical access emergency medicine is some of the most impressive that I've ever seen. So appreciating that in advance, that where you're getting involved often is seeing the same patients with less resources, and just appreciating how awesome the work is. And then also we do little things also that much of which we've been taught by Avera, which is we do camera checks at the beginning of every shift, which is under the guise of checking the equipment, but is really checking in with them, talking about the weather, seeing how the Little League World Series ended up, et cetera. So all that makes the opportunity when they need you to go so much easier.
That's really great. And I really appreciate that kind of caveat about, certainly all of us, I know this is not a simulation conference, but we all know how much simulation is a struggle, much less doing it in real time with real patients in front of our own colleagues. So thank you for acknowledging that, which is then a nice transition to my question for Dr. Olson, which is, what kind of feedback did you receive from staff regarding your virtual mental health services model? And what would you recommend to others who are interested in trying to implement this in their own shops, both to increase use and also to increase utility?
Sure. There was a range of feedback. In general, I would say everything was positive, but I did have some colleagues feel now, a few weeks after the real height of it, that they don't feel they want to keep hearing about these services, that I think it pulls them backward in a sense. And so this just goes to show that everyone has to do their own thing. But I think there's still a large number of people who really want the services. And I would say one of the more aggressive but helpful things was we all got signed up for sessions and could opt out of them. But before you knew it, it was so busy, and on your calendar, you just had an appointment. And so it was one of those things where you just might just feel inspired to hop on, which I think is possibly effective in reaching people who wouldn't ordinarily sign up for things like that.
Did you find, I'll do a follow-up question there. Did you ever do group services or kind of check-ins?
Yes, many group ones. And honestly, they're the nicest, because it gave us a chance to also just be together, see each other's faces, realize that everyone is still right here. And because this is a very isolating situation as is for all of us, everybody knows this. So getting that sense of connection, just showing up and just being there has been helpful.
Thank you very much. Dr. Greenwald, we have an interesting question, which I know has been answered on the chat in real time, but I'd love to hear your live answer too as well, which is about, if you're monitoring patients continually via video, do Do you have them fill out a consent, or how do you handle kind of that concern about the kind of constant monitoring?
Yeah, so we had some mixed feelings about that when we literally put cameras throughout the ceiling of our emergency department. And we expected a fair amount of discomfort, not only from patients, but from staff. And we posted signs giving people the opportunity to opt out. We don't record anything. I am not familiar in 2+ years of doing this now of anyone opting out, which is mind-boggling to me. I think if I were a patient, at least hypothetically, that I might consider opting out. But now that I think about it, I was recently a patient in our own ED, and they're waiting for a bed upstairs for 12 hours, and I don't think opting out crossed my mind when I was sitting there.
Fair enough. I'm glad you're okay.
Went well.
Thank you. I'm going to ask Dr. Ward the next question, which is wondering how the fact that your telehealth system was deployed within the VA, how do you think that affected your findings, particularly around the telemental health, and whether you think your results could be generalized to non-VA hospitals?
Yeah, so doing this in the VA is a bit unique. The nice part is the VA as a system's been doing this for years. You know, I think that the results, whether it's within the VA or applied outside, you're still dealing with process and patient care. And so it really doesn't matter whether it's a system like the VA or not. And actually, we used what we had developed within the VA and the same principles to be able to launch ePPE at Vanderbilt. So, you know, it's like anything. One emergency department is one emergency department. And when you're trying to scale, you have to locally adapt and what are the issues and why you're doing it. You know, this is telemental health, but we've been able to apply it to other consulting services. So now we're applying it to internal medicine, neurology, GI, but also ancillary services as well. So pharmacy, social work. And it's once you've got the infrastructure in place, as others have mentioned, you can now scale it up from there, whether it's within the same system or outside.
Awesome, thank you. Dr. Curtis, a question for you. What were the most common uses of your intervention, or if you don't have that data at hand, which patient presentations seemed the most telehealth sensitive? And this may be a pre-COVID question as much as a during COVID question.
Yeah, so our most frequent reasons that teleemergency gets engaged, first is trauma, and second is cardiac, including STEMIs, dysrhythmias, et cetera. Third is respiratory distress. Fourth is altered mental status, and none of these sound like unusual emergency medicine presentations. And even though it doesn't rise to the level by percentage of being fifth, because the overall population is smaller, we do see a fairly frequent or common population of pediatric kids. And one thing that became a little more prominent, as you'd expect during the current pandemic, was not quite as sick, but the question of how would you approach this potentially COVID PUI, both from a PPE standpoint, from a transfer standpoint, from supplemental oxygen versus high flow, et cetera. So that became a little more common than at the baseline.
Awesome, thank you. And we have about 6 minutes left. I'm going to ask the next question of Dr. Olson, and then I see there's one more live question, Dr. Curtis, for you. So Dr. Olson, regarding the nurse-free model, this goes back to the operations and the relationships, but all of us can imagine that implementing that nurse-free model must have required significant coordination with your operations team. Can you tell us a little bit about that experience, what your aha moments are, or your takeaways for those of us that might be considering this? And the final question there would actually be, do you see this outliving COVID? Do you see keeping this sort of nurse-free model going forwards, or do you really see this as a purely COVID-related innovation?
Okay, so my biggest lesson is don't roll this out with everybody. So what I discovered doing this was get a little group of people who are invested in it and try it out. So we would just do a patient here or there, see how it worked, test out the equipment, see where a different space might be better than another, and do it almost under the radar to test it out several times, and then bring it to we call our different people champions, like our PA champions and our nursing champions, who bring it out to all of their colleagues. Because to answer your second part of the question, I do see this going in post-COVID, and the whole beauty of telehealth is that you can create things and fold them all within hours in the day. And so it's that flexibility that makes it so wonderful. And so absolutely, I could see this popping up again and again as needed. And that's why you don't tell everybody right away, because it can cause a lot of confusion.
Thank you very much. All right, well, our final question for this group is, actually, Dr. Razak just put a good one in too, but I know that we only have 2 minutes left, so I'm going to go to the prior one, and then hopefully we can answer his, Dr. Razak's later. How are this is for Dr. Curtis. How are codes managed in the ED, given the time it takes to put on PPE and preventing cross-contamination? And how do you see telehealth in particular helping with that?
Yeah, so I can certainly say how we used our teleemergency service in that setting. So a little bit by the way it's set up, there is always one person in the room when the button is pushed. And with just one person in the room and all the access we have to the patient and the monitor and seeing what's going on, we can fill in whatever other roles need to be filled in while the other people are putting on their PPE. So as we all know, you can glean a lot from a quick look at the patient and a quick look at the monitor. And is it just start CPR and the next person that comes in, we give them a quick update and where we are in the code? Or is it the provider is first and we play the nursing role? So really it allowed people to feel much more comfortable doing their full PPE because there was more of a team, quote, already in the room before they got there. So that's how we approached it. In our own ED, kind of a similar approach is that that hardware could be connected either to same team or to tablet or to hub. And again, you already had an enhanced team before everybody had their PPE on.
Awesome. So I think we have 1 minute. So I'm actually going to throw this out to, gosh, any of the four of you could answer. But I'll do Dr. Ward just because of his experience with the VA as well as at Vanderbilt is Dr. Razak's question about where you see the biggest opportunity for telehealth going forwards, telemedicine, especially given our dwindling volumes that I know that all of us across the country are dealing with.
Yeah, and it's a great question. I mean, I think we all would have different answers on this. I think, ultimately, the volume's going to come back. So we haven't had an opportunity in the era of crowding to be able to divert patients from coming into the ED. It had always been once they came to the ED. This now provides us an opportunity to be able to evaluate patients before they even come in the first place, and to then more appropriately direct them. So that's one area. But there's going to be tremendous growth in this. We're not going back. This is the golden age of telehealth, and just hold on for the ride because it's going to be exciting.
We need to think of the ED as a service, not a location.
Oh, I love that. Dr. Olson and Dr. Curtis, any little quick nuggets just like that, like less than a sentence?
No, I can't top it.
I think similar is just that on a typical shift, it may only be that some of your patients are seen in your bricks and mortar setting, and some of your quote emergency patients are being seen wherever they need to be seen, and you're still providing emergency care.
Awesome. Well, thank you, all four of you, for your incredible work and for sharing your knowledge and your experience with us today. On behalf of SAEM and the larger academic emergency community, I truly, from the bottom of my heart, thank you for what you're doing, and again, for taking the time out of your day to share this. I'm going to turn this back over to the amazing Dr. Hayden to take it from here.
All right. Yes. Thank you, Dr. Rainey, and thank you for all of the panelists. And I think, Dr. Ward, you summed up one of those big questions that I think a lot of us in the audience have been wanting to figure out. What are we going to do with our dwindling volumes? And I think you spoke really well about that. And I think this is going to be a question that continues in sort of our telehealth and emergency medicine circles for a while now, while we see what happens with our volumes and with all these innovations. So thank you. We are going to take a quick break. We are going to, as you see on the slide, we're going to come back at 3:40 p.m. at Central Time. So 10 minutes, so you can get up and stretch, move around if you already aren't on your Peloton or something else right now, and take that break. We will come back and start into panel number 3 at 3:40 p.m. Thank you.
Tim, can you hear me? Okay.
Okay, welcome back everybody from our nice break there. I know you're probably enjoying this as much as I am. I've been learning so much from the first two panels, from the community paramedicine and pre-hospital, as well as telehealth being used within the emergency department. So thank you for coming back from the break to learn more. So our next panel will be on the topic of the continuum of care and remote patient monitoring. The innovations you will hear about on this panel could situate emergency medicine more squarely in the continuum of care than it has been in the past. I look forward to hearing these panelists discuss how they've used remote patient monitoring during the COVID-19 pandemic. Dr. Ian Martin will moderate this panel. Dr. Martin is the current SAEM president and the system chairman of the Department of Emergency Medicine at the Medical College of Wisconsin in Milwaukee. He is a professor with tenure in emergency medicine and internal medicine. Dr. Martin is also the emergency physician-in-chief of the Froedtert and Medical College of Wisconsin Health System. Dr. Martin has devoted his academic career to improving the delivery of emergency care internationally through program development, investigative research, and direct clinical care. Dr. Martin's research interests include determining the optimal ED-based testing models for HIV and hepatitis C, and acute care disease burden epidemiology in developing countries. Dr. Martin has garnered grant support for his research from federal and state agencies, industry, and academic institutions. Dr. Martin, it is an honor to have you moderate this panel as the president of SAEM. As a reminder for those watching live, you can use the Q&A button in Zoom to ask questions throughout the panel. Dr. Martin, I'm going to turn this over to you to introduce the panel.
Thank you, Dr. Hayden. I believe this will be my last act as SAEM president. I can't think of a better last act than this. So thank you again for the really kind introduction and for the opportunity to moderate this timely session. The COVID-19 pandemic has certainly underscored the importance of telemedicine in the care of our patients. So I'm really excited to hear from our panelists today. Without any further ado, let me introduce our experts on this panel today. So first up, we have Dr. Peter Greenwald, who is the Director of Telemedicine for the Department of Emergency Medicine at New York Presbyterian Weill Cornell Medicine. He has been deeply involved in flexing telemedicine capabilities at Weill Cornell Medicine and New York Presbyterian Hospital to meet the demands of the COVID-19 crisis. Dr. Greenwald's work in this area has been highlighted in abstract presentations at various national meetings and in the peer-reviewed medical literature. Dr. Viraj Lakdawala is Associate Professor of Emergency Medicine at NYU Grossman School of Medicine and Chief of Emergency Medicine Telehealth in the Ronald O. Perlman Department of Emergency Medicine. He developed NYU Langone's virtual urgent care in 2017 and has been the medical director of that entity since its inception. Additionally, in the telehealth space, he has consulted for or worked clinically with American Well, HealthTap, and Capsule Pharmacy. Next up, we have Dr. Tim Lang. He's a first-year clinical informatics fellow at the University of Virginia and was recently chief resident at Virginia Commonwealth University Emergency Medicine Residency Program. Dr. Lang also is helping lead the COVID-19 telehealth efforts within the University of Virginia Department of Emergency Medicine. And last up, we have Dr. Chris Davis, who is Associate Professor of Emergency Medicine and Director for Virtual Health at the University of Colorado Health. He began his journey in telemedicine when he was selected to provide medical direction for National Science Foundation teams in Greenland and the surrounding Arctic. Dr. Davis's research interests include developing novel care delivery models using telemedicine and the provision of telemedicine support in extreme environments, although his primary focus of late is expanding capacity for virtual health across his health system. So welcome to our panelists, and many thanks for the gift of your expertise and your gift of time. Now I'll turn it over to our four experts to make brief presentations to kick things off. Dr. Greenwald. Dr. Greenwald, I believe you're muted.
Yeah, you know, these headphones have a separate mute button that apparently got inadvertently pressed, so sorry. In the previous presentation, I referred to how hard we'd been hit by COVID in New York. It really was like a tsunami. At the height of the wave, we were admitting 45% of patients who arrived in the ED, and for many weeks on either side of that, the number was 40%, with over half of those going to the ICU. And in the early stages of that wave, cases were doubling in New York faster than they had in Italy. In those early stages, social distancing had just begun, and there were very real concerns about how that patient volume could outstrip our hospital capacity. Enterprise-wide, we had hundreds of patients waiting for beds in emergency departments. In that context and fearing what was to come next, our emergency department leadership across the enterprise made a joint decision to consider patients who could maintain a saturation over 90% on exertion as potential candidates for discharge. We needed, if we were going to do that, to have a safety net for those patients. And through some great and creative sourcing on the part of our institution, we were able to get hold of many hundreds of oxygen concentrators and many thousands of pulse oximetry devices that we could use to discharge these moderately hypoxic patients with. And we very rapidly deployed a system not only to get patients those devices, but to arrange video callbacks and assessments for those patients in the days that followed their ED discharge. Next slide, please. So here's a representation of the patients that we considered for discharge. And these, again, are exertional oxygen saturations. We'd have patients walk in place for a minute and see what their saturation was. Next slide. So in order to do this discharge as safely as we could, we needed to train people how to do an assessment of people at home. And at the same time, we were very consciously trying to have these assessments not be done by emergency medicine providers. Remember, we didn't know where things were going to go at the point we were making these decisions. And we were under the assumption that those emergency medicine providers would either be very hard hit by the disease themselves, or even if they weren't, that we would have a continued crush of patients and that those EM doctors would be needed face to face. So we developed training videos and tightly scripted dyspnea assessment pathways. And we used redeployed staff from other areas to perform these assessments on patients we'd sent home. Next slide. So this is a picture, and I don't expect anyone to read it all here, of this tightly scripted pathway that we had a group primarily made of nurse practitioners that's previous job was doing pre-op assessments, execute this assessment with patients for 7 days after they left the emergency department. This is one of those cases where we made good use of that HIPAA waiver of enforcement. These were patients who'd never had a video visit before, and you can imagine the technical hurdles to getting them on the fly while they're ill to do a video assessment. But using commercial conferencing software, we were able to send out a link, have the patients click the link, be guided to download an app on their phone, or just have the program launch from a browser and initiate a video visit. It didn't work for everyone. We were able to do this about 60% of the time. The remainder of the patients, we did, again, tightly scripted telephone assessment that I know there's been a lot of discussion back and forth about it, but using primarily an assessment of heart rate and single breath count test, which is where you see how many numbers you can get up to within a single breath. That's what we did when we did phone assessments. When we did video assessments, we did vital signs, including heart rate and respiratory rate at rest. And remember, we'd sent all these patients home with a pulse oximeter so they could hold it up to the camera and we could actually read the pulse oximeter, bypassing the difficulty that we found many patients had in doing accurate assessments of their own pulse ox tracing. And then we'd have them again walk in place for a minute and repeat the assessment. And patients who fell outside of parameters we'd set for vital signs would be directed back to the emergency department. Patients where things were unclear, the nurse practitioners and others as the system grew had access to EM physicians to immediately in real time escalate care with while the patient was still on the camera. We're looking forward to analyzing the data from this, and I don't think sending somebody home with an exertional SAT of 90% who previously was believed to have normal lung function would be a good idea in normal times. I think it was a good idea with what we knew at the time when we initiated this. And I think we've learned a lot about how we can safely protect patients at home going forward. Even though we might not, I hope we're not, in the position to do this again, I think for the foreseeable future, we will be sending patients home with COVID-like illness. And that illness will remain unpredictable. And a portion of those patients will be at risk for deterioration at home. And maybe a deterioration that they're not even aware of, since we know people get quite hypoxic without feeling dyspneic. And we're hoping to take the lessons from this and apply them. And not only hoping, we're actively in the process of doing it, of taking these lessons and applying them to the less ill patients with COVID illness that we're currently discharging home. Now, let me hand off to my New York colleague, Dr. Lakadalwa.
Thanks, Peter. So I don't have slides. I'm saving you all from having to stare at a bunch of numbers and figures and graphs. So I'm just going to sort of speak to our experience. And I'm going to focus my conversation on how we followed up patients, both from the virtual urgent care as well as the emergency department. And we started our virtual urgent care in 2017, and we had a slow rise of volumes to a max of about 30 per day pre-COVID. And shortly thereafter, we went from 30 to 60 to about 1,000 a day during peak COVID. Now, with this, we were already following up patients who had seen our virtual urgent care and ED through our ED follow-up center, which is basically staffed by NPs, PAs, and RNs to follow up on patients that have been seen in the ED or VUC within the next 24 to 48 hours. Now, as you can imagine, staffing up a virtual urgent care to see 1,000 per day from 30 per day required quite a bit of extra bodies to see these patients, as did the same thing for our follow-up center. So we were lucky in that NYU, being a large health system, had a large ambulatory network as well that happened to basically shut down. So with the entire outpatient network shutting down temporarily, we were able to make use of providers, both RNs, NPs, PAs, to help staff the follow-up center, as well as we were able to leverage some of the primary care physicians, GI specialists, rheumatologists, et cetera, to come help us out to be attendings on the virtual urgent care as well. Now, we during the initial chart reviews over the first couple weeks of the COVID surge, we did notice that there was a trend for sicker patients that would have normally gone to the ED to come to us on virtual urgent care. And we were referring patients from the virtual urgent care to the ED at a higher rate than we normally did. And we generally had, before COVID, it was very low acuity, simple things that we would see on VUC. And now we're seeing COVID patients with respiratory distress, some with severe malaise, and who are likely hypotensive, just lying there in bed, unable to get up, called 911 for a number of many patients from their homes for them. So we noticed that with these higher rates of ED referrals, we noticed actual expirations of patients in the setting of a recent VUC visit. So with this, we decided to do a rapid assessment of risk factors for deterioration from a VUC visit, and noticed sort of a bimodal trend of patients deteriorating pretty much immediately after a VUC visit within the next 48 hours, as well as those that are deteriorating about 7 to 10 days after a VUC visit. So basically, from this assessment, we decided to create an additional follow-up workflow that paralleled our regular follow-up center. We took some of our PAs and other providers that were working on virtual urgent care and did a telephonic reassessment within 48 hours. Basically, this additional telephonic reassessment provided an additional 5% referrals to the ED. And we also were able to reevaluate these patients through virtual urgent care as needed, if they felt uncomfortable with going or if they sounded okay on the phone. After this 48-hour phone call, the follow-up center, which was already lagging behind a bit, was basically calling patients about 5 to 7 days out. So that was where our second phone call captured additional patients who might be deteriorating or on the verge of deteriorating, and sending those patients to the ED as well. So all in all, we were able to notice a difference in the number of patients that were acutely deteriorating after immediately after a VUC visit, as well as delayed deterioration, and notice that our efforts did show a little bit of a drop in that. While it could be said that maybe there was some effect of the follow-up center changes, this could also be because we're kind of on the back end of the COVID surge. But it was good to see that we were able to take a workflow that we had, and we were able to expand on it and rapidly scale up. Because if we didn't have the infrastructure in place, and I think we've talked about this before, if your infrastructure doesn't exist already, there's no way to ramp it up. You're going to be scrambling to set something up brand new to cope with a new surge of patients. So for what will likely, hopefully not, but there will probably be a second spike at some point. It's better to be ready and prepared and ready to ramp up before it hits. That's all I got. Thank you. And I'm going to pass it on to Dr. Lang now. Thank you.
Perfect. Thank you. Like Dr. Martin said, I'm a first-year informatics fellow at the University of Virginia. And it just so turned out that my telehealth rotations were scheduled for March and April of this year. So probably couldn't have been a better time to really see telemedicine come to the forefront and shine. And you go to the next slide. And I think one of the biggest things that I was able to kind of realize was that to what everyone else has said so far is that standing something up like this from the ground up during this would have been almost impossible. And we were lucky at UVA to have really strong background in telemedicine, led by Karen Rubin, who will be on the next panel. She's our medical director of telemedicine. And we also have a very strong presence in our Dr. Thompson, who for years now have set up a collaboration with Locus Health, which is a third-party vendor that does in-home monitoring. So they initially looked at patients that were qualified CMS patients from inpatient discharges they looked at reducing hospital readmissions in 30 days, and they were able to find a good correlation with in-home monitoring for that. And then when they were swinging and preparing for this possible COVID surge here at UVA, they wanted to really capitalize on this type of technology and reached out to the emergency department to see if we would be interested. And we were really happy that they were willing to work with us, really focusing on PUI from the emergency department, as well as persons under investigation from the COVID clinic. And then on the other side of things, they were just continuing their what they'd already set up for COVID positive patients that were admitted to the hospital and then discharged. And when this started, our initial turnaround times for tests was about 5 days through the commercial labs. And then it turned into 24 to 48 hours through our own lab. And now we have a 2-hour test, but that is kind of so specialized for certain populations that the 24-hour test is what we're kind of going back on. And if patients are symptomatic, we're able to provide, but don't need hospital admission, we're able to provide this service of in-home monitoring to them. So you can go to the next slide. So the workflow is that if we identify a patient in the emergency department that is symptomatic, but does not need hospital admission, but has some certain comorbidities, they're in an elderly age group, they have positive before, we're able to set up this in-home monitoring. If they're within 50 miles and it's before 4 p.m., we can get that delivered to them the same day as they're discharged from the emergency department. If it's after 4 p.m., it's delivered the next day. And if they're outside of 50-mile radius, it's shipped overnight and set up for that patient. They're delivered an iPad, a pressure cuff, pulse ox, and a thermometer, and they're requested to import their own vitals and every 4 hours into a dashboard, specifically through the Locus Health platform on that iPad that then feeds right into Epic. And anyone that is in that patient's chart in Epic can click and be brought to that same dashboard to see kind of how their vitals have been trending. So this program will monitor patients that are positive for 30 days of in-home monitoring. And if we're seeing them in the emergency department, they're having symptoms that are consistent with COVID, cough, shortness of breath, some minor hypoxia, then we can send the test. And if it ends up being negative, they'll still get 7 days of in-home monitoring after that negative test does result. They also get a daily call by the APP team that is monitoring these dashboards. I believe they had a team of about 9 APPs that were taking 12-hour shifts, doing sign out on all the patients in between each shift. And they're documenting all of these calls in Epic. And like I said, you can see all the vitals and trends throughout that patient's in-home monitoring through a link in Epic. And then any patients that are decompensating, if they can come by POV if they have family members or anyone else that can take them to the ED, or the APPs are calling 911 for them and having them transported to the ED. And I think, when I was talking to Novella Thompson about this and going over some of the numbers, I think we didn't have as many patients enrolled in this as we wanted, but I think that was partially a function of just how low our volumes have been in the emergency department, similar to what everyone is experiencing. It seems like we combined from the COVID clinic and the ED, we had about 56 patients. 36 of those came right from the emergency department, and 5 of those needed escalation back to the ED, and then were admitted. So was able to catch a couple patients that were symptomatic. I think only 3 of those 5 that were readmitted, or 2 of those 5 that were readmitted ended up testing positive for COVID after negative swabs, but it was able to catch a subset of patients. And just my experience of being in the emergency department and offering this to patients and following up on patients that were kind of symptomatic but ended up being negative, it provided a lot of reassurance to the patient to know that they were going to be followed, and have someone calling them for the next kind of days, following up on their COVID swab. And it provided a little bit more of a cushion to get these patients safely dispositioned out of the emergency department. One of the things that I think we probably could have had more information displayed to the providers to make sure that they remember they could offer this. Because whenever I was working with the residents and saying, this patient is great for in-home monitoring, it was more of kind of, oh yeah, I forgot about that. So I think more education on this and keeping it kind of at the forefront of our thoughts will help get more patients enrolled in this. So overall, it was a great experience for us at UVA in the emergency department. So I think now I can pass it off to Dr. Davis.
Thanks, Dr. Lang. How's my audio? Everyone hear me okay? Perfect.
Sound
Thanks,
great.
Peter. Good. So thanks again. Just being able to just participate in this event has been absolutely fascinating, and so many lessons learned here. Again, I'm an emergency physician by training, and I serve as our medical director for virtual health for our health system in Colorado. And I'll talk briefly about our experience with RPM, if you're willing to move forward to the next slide here. So, and this will be a good chance too to just do a recap of all the great use cases that have just been presented by our panelists, right? RPM is a fantastic way to provide a safety net for COVID-19, but likely for future conditions as well, and especially for conditions that we just don't have a lot of data in, and where the clinical course is ill-defined. And those at-risk populations, it can be because it's clinical, but they can also be because you have an at-risk population that has socioeconomic risk factors as well. It just doesn't have good follow-up. I think we heard some very compelling examples that this is a great tool to ease burden on inpatient census and to conserve PPE. And it can also be a great tool if you're monitoring your own workforce to get your own healthcare workers back to work as efficiently as possible. And this is a question I think that is on a lot of people's minds, and whether or not this is even relevant to emergency medicine. And if I were to look into my crystal ball, I think remote patient monitoring is part of our future. And the way I like to think about it is that this is just a new type of observation. We're just doing it at home, and we may be stretching out, how long we're watching these people, and from 23 hours to, frankly, to 23 days. But that's I think a good way to think about this. Next slide, please. So we used RPM in a couple of different ways. I'm going to speak mostly about the program that we used for our recently discharged patients with COVID-19. We did use a simpler program that was mainly sort of structured around patient-recorded outcome measures or PROMs for our own employees. But we didn't want to. From basically advice from my boss is don't let a crisis be a wasted opportunity to move the needle on projects, and that's how we thought about RPM. So we took, as I mentioned, some pretty sick patients who had finished their hospital course, and this could have been weeks long. We had one patient who survived ECMO, but mostly patients who were earlier in the course of their illness. And we focused on that population. We provided them with a device that could continuously stream vital signs. And that's sort of an important sort of, I guess, sort of pin to put in RPM. Again, there's simple ways to do this just with sort of patient symptom questionnaires. There's more complicated sort of spot checks of vital signs, and then there's continuous vital signs as well. And a lot of this, a lot of the capability, you need to be pragmatic about what you're choosing and what your application is. But we wanted to experiment with this. This was our first use case where we were streaming an enormous amount of data into our virtual health center. And as we've heard time and again, you got to use the resources that you've got. And we had a fairly robust virtual health center that had 24/7 technicians, nurses, APPs, and docs. And that was the team that we leveraged to look at this data and look for respiratory deterioration. And then we would overlay on top of that vital sign information, daily symptom checks. So what did we learn from this? So again, as they come back to these themes, the tech is never the hardest part. Remote patient monitoring, in our experience, was very much a multidisciplinary affair. We had to bring in care management, social work for housing, our RT team for home oxygen, and follow was critical. Developing sort of the communication infrastructure for loop closure was a big deal. But again, my advice for other people looking at or watching this seminar is, use COVID-19 as that learning platform to address many of these barriers, both to telehealth broadly, to RPM specifically around compliance and billing barriers. As I mentioned before, be pragmatic, use what you've got. This doesn't need to be sort of the fanciest and most technically complex program in the world, but it's worth dipping a toe into. And then lastly, it does make a difference. Again, we saw a rescue rate in our cohort of patients of about 10%, where we were finding something, either hypoxemia that we missed on the assessment just prior to discharge. We saved on a patient who was sent home, but lived quite far from the hospital and ran out of oxygen before the oxygen delivery company could deliver more. And it was quite stressful watching them getting hypoxemic. So it's pretty amazing what you're able to actually intervene on and likely save as a readmission. So with that, I'll hand things back off to Dr. Martin, and we'll transition to questions.
All right. Well, thank you, Drs. Greenwald, Lakdawala, Lang, and Davis for those great presentations. And now I'd like for us to field some questions. I do invite our audience to send in some virtual questions. We've compiled some for the panel as well, and there'll be a mixture of questions that I'll point to the whole of the panel and some directed to individuals. So I'm going to start with perhaps a somewhat provocative question. I at least know Dr. Davis's bias on this given his remarks just a few minutes ago. But so the question is, why should emergency medicine physicians be involved in managing patients undergoing in-home monitoring as part of their care? Is this beyond the scope of practice of emergency medicine? And I'll just invite each of our panelists to weigh in on that.
How about we, do you want to go in order? Peter, do you want to take this first?
Absolutely. That sounds great. So what am I interested in as an EM physician when I'm sending someone home? I'm interested that they're going to be safe at home. Who do I most trust to make them safe? Well, that would be me. If I have someone else to hand them off to, great. I imagine most of our audience here finds it's very easy to get next day appointments for their patients when they send them home. If you're working in an environment like that and you have someone who can check in on your patients Thursday, Friday, Saturday, Sunday, great. Make use of that person. Otherwise, I think it's us. And I'm more than happy to do what's necessary to keep my patients safe.
Peter?
I'm going to agree with that. At NYU, we developed our follow-up center, which is basically our own ED nurses plus NPs and PAs that we've brought on board to provide, these follow-up phone calls, which sometimes lead to repeat ED visits. But now, after the start of our virtual urgent care, we were basically using our virtual urgent care as kind of a safety net now to provide additional follow-up care for patients that can't obtain it after an ED visit. We do now take Medicaid, Medicare, a lot of the commercial payers, most commercial payers as well. So we were able to, make this a low cost, no cost follow-up visit for the patient to provide that additional layer of support after an ED discharge. So I think if we can hold on to the ball as long as we can, I think I agree. We are the best caretakers for our patient in the acute setting.
Thank you.
I completely agree as well. I think having recently completed residency and now being the attending, making the decision to ultimately discharge a patient to the home, it weighs on me a lot more than I think it did in residency, since you're making that final decision. Having something like this and those kind of nebulous patients where you would just like someone to call them the next day or call them up, which I've been doing on my own since we don't have as robust of a follow-up kind of department here at UVA. I think this just extends the care we're providing in the ED and make sure all the dispositions that we come up with are as safe as possible.
And I've tipped my hand on this.
Sure
but
did.
I think, as I mentioned, I mean, and frankly, as Dr. Hollander has mentioned, we are problem solvers. We're great at solving and making decisions in data sparse environments. That's perfectly suited to remote patient monitoring. We understand health systems and work in multidisciplinary teams. That's a great fit with RPM. And frankly, again, when, and I think Dr. Hayden mentioned this, we need to think about what healthcare is going to look like after COVID, both in a year, but also in 5 and 10 years. And diversifying how we can intersect with healthcare is going to be critical.
Were your faculties largely, did they largely embrace this, or did you get a lot of pushback? And if so, what were some of the techniques you used to get them over the hump?
Yeah, I'll take that one. We, our census and our emergency departments, like probably many's, we're down 40, even 50%. And so it was an relatively easy sell to say, hey, we're going to redeploy a shift and start to do this work. And granted, we did this work and also glom this on to virtual urgent care and just sort of overall virtual triage that worked really quite well. And it's pretty easy to sell a change like this when this is decision or we need to think about furloughs and layoffs. That sort of is quite compelling.
At the time we were initiating this, there was a crisis, and getting people to step forward in a crisis is, we're good at that. Almost everyone in healthcare is good at that. Actually, in a way, I'm facing that problem now. Now that this is no longer as exciting a thing to deal with and everyone is tired, who are we going to have do these follow-up calls? Where's the best place for that to live? That's very much an active discussion at my institution now.
Thank you for that. So I'm actually going to give you the next question as well, Dr. Greenwald. So you all have really described some amazing programs that you've instituted at your various institutions. I'm wondering how you adapted this, and we'll open it to some of the other panelists after you have an opportunity to respond. But how did you make adjustments to this program to care for those who were homeless?
We had a few people who were homeless go home under this protocol, and it didn't work very well. And they were difficult to get back on the phone, even if we could reach the shelter where they were, or even if we had their cell phone, it sometimes went unanswered. It was only a few patients, and we'd never intended to discharge patients who were alone in this program. But when we found a few patients, and the reason we found them is because we had very close follow-up with the group doing these calls. When we found these patients, we needed to re-message how important it was that people have stable environments to go home to. So the way we made homeless people safe who had COVID-like illnesses, we admitted them to the hospital.
Any other experience with that at your institutions?
We had we had a similar experience at Bellevue and NYU is given the lack of social support for these patients and even just difficulty dealing with the New York City Department of Health and Homeless Services. They had isolation beds at shelters available, but getting someone on the phone to actually get someone there was becoming a 10 to 12 hour proposition. And the safest place for someone without a social support or someone to just keep an eye on them was just admitting them to the hospital. So we admitted a large number of our homeless population that were like kind of borderline.
Thank you. So Dr. Lang, looks like you have a comment.
Yeah, so we had partnered with a local hotel that had agreed to take COVID positive patients that we thought they were safe for charge out. And then they were set up with a similar Locus Health in remote patient monitoring, but they weren't given the iPad and the supplies. They were writing down their vitals, and we would have someone kind of go check on them and write down the vitals that they had and input the vitals into the system that they had written down, so that we weren't kind of providing those tools right to the patient. And then this was biggest of a problem when we didn't have a rapid turnaround test, especially if it was 48 hours. But now it's turned, since we have a rapid turnaround test, a lot of the patients that are homeless are getting that rapid test kind of weighed with their pretest probability to see if they're safe discharges with a negative test.
Thank you. Dr. Lakdawala, the next question is for you. And in the use of telehealth and post-discharge emergency care, how do you ensure quality and consistency of these various programs?
So, we had a large number of new providers come on board during COVID, and so I had to leverage some of our other administrative leadership to help QA charts for all these new people. So we were QAing charts for the newest attendings coming on board at a higher rate than we were before to maintain some of that quality of care, and actively monitoring basically some outcomes of patients and giving feedback to the providers. We now had PAs and attendings and giving active feedback to these providers on a regular basis. We had educational emails going out almost every other day, giving updates on COVID, what was new, what to look out for, breath holding tests, et cetera, just to make sure that we were appropriately monitoring patients and documenting respiratory status. So testing the right patients, not testing the right patients. It was a constant barrage of outgoing communication from our team.
Thank you. This next question is for Dr. Greenwald. It's a sort of similar question, and that is with regard to remote monitoring. So how do you ensure safety, and what do you do when you determine a patient needs a higher level of care than can be provided at home?
Yeah, so the last part's easier to answer. We brought them back to the emergency department, and we instituted variations of the protocol that I was discussing throughout the enterprise. And almost all locations had roughly a 15% return rate. These weren't medical reassessments in the broader sense. These were very tightly scripted dyspnea assessments that almost had a call center regimentation to them. Okay. There was scripted language. The providers doing these assessments were taught in a one-on-one environment where they watched several, then had several cases observed, and then had real-time access to their supervision. And this group grew to include residents from a variety of specialties, some PAs, but at the core of this group, and always more than 50% of the providers, was these preoperative nurse practitioners. And I think their prior working environment actually predisposed them to be able to do a regimented step-by-step workflow like that very well. I personally observed quite a few of these visits. But when stuff didn't go according to script, they had 5 ED docs that they would call one after the other until one picked up. I would get a couple of these calls a day, and I would usually miss 1 or 2 of these calls a day just because I didn't pick up the phone fast enough. And then they would discuss through the case with the provider on the line. The result of that conversation either could be, I agree with you, they stay home. I agree with you, they should come to the emergency department, even though they don't rigidly fit the criteria. Or occasionally, could you instruct the patient how to have a virtual care visit with one of my EM colleagues who's on right now?
And if the patient needed to go to the emergency department, did you all called 911 for the patient? And was there sort of a handoff to your colleagues who were on shift?
So our standard is a warm handoff to the receiving emergency department, which may or may not have been one of our institutions, depending on where the patient was at home. Okay. Very often it was, because these patients had previously been seen in REDs and had an affinity for our hospital system, even if we weren't necessarily the closest. And whether that was 911 or private transportation was a discussion between the person doing the callback and the patient, and very often the patient's family.
Very good. Thank you. So this question, actually, the next one is for Dr. Davis and Dr. Greenwald. So obviously, there are a number of touch points in the care of these patients across this continuum. So I'm curious about, are the patients billed for this post-discharge telehealth emergency care? And if so, can you tell us a little bit about that billing process?
Yeah, let me start with that. I think we've touched on this a number of times where, again, COVID affects socioeconomically disadvantaged people at higher rates. And so we didn't want to disincentivize patients from participating with just even the idea that they might get billed. And so specifically, we have not been billing for COVID RPM. Now, that being said, we've been putting all the infrastructure in place to bill for this service for the next condition down the line, and whether or not, again, that's we have plans for a virtual diabetes center and other chronic care management. I think truly that the takeaway, though, is that this, especially with the new CMS codes, I suspect that we may hear something about from the next panel. This is absolutely, there's an opportunity to at least make a sustainable program for future use cases.
Thank you. Dr. Greenwald, do you want to add anything?
I'm really proud of our institution. We sourced these hundreds of oxygen concentrators, and the initial shipment of pulse oximeters was 5,000 of them. And we distributed those to patients without regard to ability to pay or insurance, and we did not bill for them, nor did we bill for the follow-up phone calls. It was a crisis, and it seemed like the right thing to do. And I'm really proud that we made those decisions.
Is that likely the business model? You said you've sort of shifted into recovery mode, and what the longer term plan looks like for telemedicine at your institution. Are you actively having those sorts of conversations now?
We haven't changed our processes. We're not routinely discharging patients who are moderately hypoxic right now, but we're still giving out free pulse oximeters and still doing follow-up phone visits. I think we're going to have to think about, well, the institution needs to survive. So we need to think about ways of getting paid for the services we offer. And those conversations are going on.
Fair enough. Thank you. In that this is an academic gathering, I'm curious about how you've integrated learners into these various telehealth programs. And I'll open that to we will start with you, Dr. Lang, but if others from the panel want to chime in.
Specifically with remote patient monitoring, we haven't involved the residents at all with that, but our institution is heavily involved with trying to get a direct-to-consumer telehealth virtual urgent care model off the ground, and our ED wants residents to be part of that if we kind of continue down that pathway, and then kind of teaching the residents how to decrease the number of times they're going into a room, and reminding them they can, video in, I think is something I've tried to reassure the patient or remind the residents they can do on shift. But as far as specifically remote patient monitoring, there we do not have residents involved in that.
Any others at some of the other institutions? Have you integrated?
So we haven't integrated residents into any of our virtual health programs just yet. We have sort of down our pipeline a teletoxicology service. We're going to start providing toxicology consults through the New York Poison Center for the NYU toxicology fellows to our remote EDs, so out on Long Island, in Brooklyn. So we're going to start providing remote toxicology consults that way. Right now, everything's done by telephone to all the EDs in New York City. But given that they are NYU trainees, we can provide that video access to our other campuses. We currently have med students providing discharge counseling to patients with COVID. We've sort of scripted out an FAQ for them, and they're basically functioning as the discharge nurse rather than the discharge nurse providing the discharge papers and giving them a brief like, here you go and on your way. This is giving the med students a little bit more of an opportunity to speak to patients at a little bit more length and depth to discuss next steps for the patient and counsel them a bit. So that's kind of where we are right now. As far as getting the residents on our virtual urgent care, we're coming up against some stumbling blocks for that, both regulatory wise and billing wise, and so we're hoping to push beyond that and see where we can go.
Well, it looks like we're at time. I want to thank all of our panelists for really these great presentations and for fielding so many of these questions this afternoon. I know I certainly learned a lot, and I'm sure a number of our audience members also. So thank you again. And now I'll turn it back over to Dr. Hayden.
Great, thank you. So yeah, I agree. Fantastic discussion, and I really do think that this discussion about or debate about where emergency medicine should be in this remote patient monitoring space and continuum of care. We are really good at that acute unscheduled care, and when there's a problem with something in remote patient monitoring, should we be the ones responding, and sort of how far do we go into the home? Are we going to then be following patients and adjusting their blood pressure medication? So I think many of us would say, ooh, we don't know if we want to go into that. So the future is going to be determined. In the future, we need to decide. And I really applaud the group of you that have already been doing this at your institutions, because we will learn from you guys. So, all right, so we're going to move along. Our fourth panel today will be on the topic of regulatory updates and will be moderated by Dr. Rahul Sharma. Dr. Sharma is a professor and inaugural chairman of the Department of Emergency Medicine at Weill Cornell Medicine and serves as the emergency physician-in-chief for New York Presbyterian Weill Cornell Medical Center. Dr. Sharma is also professor of clinical healthcare policy and research and serves as the academic chairman for the NYP Weill Cornell Medical affiliated emergency departments at New York Presbyterian Queens and New York Presbyterian Methodist, Brooklyn Methodist. And I know that there are probably things, Dr. Sharma, you've seen with these different hospitals, especially in Queens there, that none of us could imagine for those of us not in New York City. So thank you for what you've done. Dr. Sharma holds several other executive leadership roles, including Chief and Medical Director of Emergency Medical Services for the NYP Enterprise, and a member of the New York State Board of Medicine, and the Vice President of the NYP Hospital Medical Board. He's a national leader in the fields of emergency medicine, healthcare operations, telemedicine, and virtual care. In 2019, he was named a top 25 innovator in the healthcare industry by Modern Healthcare, and he was one of EMRA's 45 under 45 influencers in emergency medicine. Thank you, Dr. Sharma, for taking the time to moderate this panel. And just a reminder to the live audience, please do put your question and answers in this box. The regulatory environment is one that I think all of us on this panel, moderators, panelists, content experts, are struggling to really understand. And we think we have maybe a part of it, but hopefully we'll have much more information from this expert panel. So Dr. Sharma, I'm going to hand it off to you now.
Great. Thank you so much, Emily, for asking me to moderate this session. I always say they save the best for last, and I would say that one of the biggest challenges in telehealth was the regulatory aspect. And it seems that there were many challenges, there still are, and with COVID, there were many changes. And the next panel of speakers, and we have a great panel, are going to give you an overview of some of the aspects of telehealth that were impacted by COVID. So before we move on to the presentation, I just want to introduce you to some of our exceptional speakers. Dr. James Marson, he's a professor and vice chair for research in the Department of Pediatrics at UC Davis School of Medicine, and he's the director of the Center of Health and Technology at UC Davis Health. He has a passion for pediatric teleemergency. He just recently completed the first randomized trial of pediatric teleemergency at 15 sites on 700 patients. So we're waiting for the publication on that one. And also he's starting a PCORI grant on virtual pediatric trauma care using teleemergency for injured children. Then Dr. Karen Ruban is a professor of pediatrics at the University of Virginia School of Medicine, the director of the Center for Telehealth at University of Virginia, and also Dean for Continuing Education and External Affairs at University of Virginia. She's past president of the American Telemedicine Association and a board chair of the Virginia Telehealth Network. She developed a telemedicine program in the mid-90s, building on UVA's long history of driving remote patient outreach clinics. She's dedicated to transforming public policy to align with clinical use cases and patient needs. And she led UVA's institutional strategic plan for virtual care. Finally, we'll be hearing from Dr. Elizabeth Kropinski. She's professor and vice chair for research at Emory University in the Department of Radiology and Imaging Sciences, and a subject matter expert for the Emory Telehealth program. She's also past president of the American Telehealth Association, past chair of Society for Imaging, Informatics, and Medicine, and co-editor of the Journal of Telemedicine and Telecare, as well as on the editorial board of Telemedicine and eHealth Journal, both respective journals in telemedicine. She got involved with telemedicine about 30 years ago by chance and never looked back. Her real job is radiology researching, being a radiology researcher and seeing the impact on technology and decision making. Her current focus is on mentoring and fostering next generation of researchers and clinical scientists. So with that, I'm going to have Dr. Marson give his presentation on emergency medicine and telemedicine during COVID-19. Dr. Marson, please take over.
All right, thank you very much. And again, thanks to the organizers of this event for including me. As Dr. Sharma alluded to the fact, I am not an emergency medicine physician, and in fact, I'm a pediatrician. I work in the pediatric ICU. So my experience and expertise has been in hospital-to-hospital pediatric teleemergency programs. Here at UC Davis, we're involved with more than 30 hospitals in this network like that. So I really appreciate the opportunity to speak. So thank you very much. And then the next slide. And the thing that kind of, I give that history, what I have been involved with, I want to admit something that I had very wrong. I've had the honor and privilege to work on a number of emergency preparedness grants and programs in the county, state, western region of the United States. And I think that my planning on the use of telemedicine and how it would be used in emergency medicine, emergency preparedness was wrong. Instead of it being primarily used for first responders and hospital-to-hospital emergencies, as I was thinking, the real explosion has been in the outpatient use of telemedicine in the ambulatory setting, as we've heard throughout the day, from the provider to the patient at their home. And in fact, we've heard experiences from New York and other cities that have been busy, but they are the exceptions. ED visits and observation services nationally are down 40% and 47% respectively. Health systems on average, a 56% decline in their patient volume during the past couple of months. And financially, this has been a big hit to health systems and hospitals with an average daily loss of $1.4 billion per day. How it applies to emergency medicine is, as we've heard lots of examples today, not to go through those, but is the use of telemedicine in forward triage, or the sorting of patients before they arrive in the emergency department, or teletriage, or EPPP, which has been mentioned at Vanderbilt. And again, the explosion of video visits in the more ambulatory setting. So the next slide here, what I'm going to talk about is federal policy here. So these next two slides that I have regards with primarily CMS. So as many of you have heard, there's been the lifting of the originating site restrictions. And so for those of you that are not familiar with the term, originating site is where the patient is. The distant site is where the provider or the specialist is. So it kind of reverses our terminology that we might be used to in a hub and spoke, where now the spoke is the originating site. And before CMS and Medicare, to be able to provide services and bill for those services, the patient had to be located in a rural location. And since COVID, that restriction has not only been lifted, do they not have to be in a rural area, but an originating site, or the patient can be located even in their home. There's also been lifting of technology requirements. And the biggest factor in this, and again, it's been previously mentioned, is the HIPAA enforcement and the allowance of telephone to be used for video visits. I think it was pointed out at the very beginning by Dr. Hollander that it's very important to maintain or have a long-term plan of HIPAA security with this. So this doesn't mean we should all set up telemedicine programs that are based on non-HIPAA compliant technologies or telecommunications. But in these rare instances where those have to be used, I think that there is permission granted to us. There's also been telephone calls are allowed now, and they can be billed similarly as outpatient E&M codes. I have the list of codes there. There's been lifting of cost sharing requirements. So co-pays that had been required under Medicare are now reduced or waived. There have been lifting of EMTALA regulations so that the medical screening exam now does not have to be done in person, but can be done over video. And the provider in these instances, just like we've heard in these cases, can be remote for that. There's also been licensing and credentialing changes. To note that those interstate licensure agreements, still you have to check with the state that you're providing telemedicine in. While federally it's allowed, it's still under the jurisdiction of the states. Next slide, please. This is just a list of the different codes that I wanted to present to you. If you're familiar with these, the telehealth service visits, the E&M codes for emergency department, critical care, observation, home visits, nursing facilities, all of those are allowed now to be done over telemedicine. The POS, which is not maybe what you're thinking, but the place of service is the same, which is the emergency department 23, but there is a modifier added to that claim for Medicare, which is 95. There's telephone E&M codes for new and established patients. And again, those codes are listed below for physician and qualified health providers, as well as healthcare providers that are non-physicians. So again, all of these from the standpoint of Medicare, restrictions have been lifted, so they should be able to be provided and reimbursed just as if they were given in person. So that's my recap on my slides. And next, I'd like to hand it over to esteemed colleague, Dr. Karen Ruban. Thank you.
All right, can you hear me? Yes. Okay. Thank you, Jim. Thank you so much, Dr. Marson. Good afternoon. Thank you for inviting me, another interloper pediatrician, in this fabulous day of programming. I have learned a lot about models that you all are deploying. I also want to give a huge note of gratitude to all of you emergency medicine physicians who are caring for COVID-19 patients, and in particular, the New Yorkers. I am a native of Queens, New York, so Dr. Sharma, thanks for what you're doing in my own hometown, and all the rest of you as well. So in the next few minutes, I would like to review the digital health transformations that have been propelled by policy changes, including on a state level. As alluded to earlier by Dr. Hollander, above and beyond federal statutes and regulations, the states play a critical role in governing healthcare and telehealth practice. Federal policy establishes the floor, state policy supersedes federal. So to reiterate what we've heard this afternoon, telehealth solutions have been greatly advanced in response to the COVID-19 pandemic across inpatient, outpatient, and post-acute settings by improving access to care and to testing, and improving triage. And we just signed in the Commonwealth of Virginia a contract with a to create a statewide AI-enabled virtual triage model that has also been deployed in the Commonwealth of Massachusetts. States have enabled greater management of patients at home, including remote monitoring by changes in their policies, by reducing patient and provider exposure and conserving PPE, providing PPE as well at the state level, by backfilling primary care and specialty visits virtually, by providing virtual urgent and emergency care where there are new payment models that have been alluded to, and by enhancing connectivity with EMS providers, another role that the states have taken on. For all of these, state laws, regulations, and the management of special populations greatly impact telehealth practice, including in all of the above settings. And I might also add, in our Commonwealth, the Virginia Department of Health deployed an emergency department information exchange that has been utilized very broadly over the past several years. Next slide, please. So following the declaration of a public health emergency, most governors issued executive orders that have enabled the expansion of telehealth practice over and above prior regulations that impacted telehealth. However, as with pre-COVID-19, these are not at all uniform across the states. You've seen one state, you've seen one state. So states govern a number of different policies related to telehealth practice: reimbursement, licensure, HIPAA regulations, prescribing regulations, malpractice and liability, including in an emergency. And states also control correctional healthcare populations and oversee care in other congregate settings and in schools as well. So for reimbursement, prior to COVID-19, states themselves have different Medicaid coverage programs. Post-COVID-19, many state Medicaid programs have greatly increased coverage, including to the home, including telephone visits as well. Each of the states may or may not have commercial plan parity reimbursement statutes. Virginia implemented a broad-ranging private pay parity reimbursement statute in 2010, and many other states have done the same. And those then help define coverage for virtual visits to the home as an eligible originating site, activation of phone codes, and remote monitoring codes. State licensure policies do vary across the states. Some states have engaged in the Federation of State Medical Board Licensure Compact. We have expedited licensure, but have not broadly opened up licensure post-COVID-19. We have a licensure by endorsement process. We have the opportunity to explore a reciprocity process, but our executive order issued by our governor allows for continuity of care without licensure and the ability for healthcare systems to contract with non-Virginia licensed providers. Other states have completely eliminated the licensure requirements. State HIPAA regulations, again, Jim mentioned the federal waiver of enforcement action for use of non-HIPAA compliant devices, but it's important that providers know what's happening at the state level as well. Same for state prescribing regulations. Some states prior to COVID-19 required a prior in-person visit before prescribing. So again, one needs to be very careful that one tests and understands all the state statutes. We've had a liability waiver in an emergency, but every state has different malpractice statutes. In Virginia, we have a cap, other states do not. So again, very important to consider if you are expanding your practice across state lines that you are familiar with the state regulations impacting it. Next slide, please. So where do we go from here? To ensure that the digital health reforms and investments that were rapidly scaled in response to COVID-19 will endure, it's really imperative that we all engage together in federal and state public policy advocacy, informed both by outcomes and cost data. Whether in preparation for what likely will be a cyclic nature of COVID-19 or in preparation for any future public health emergency, we healthcare providers and systems must be ready. And with the amazing response from patients, it's not likely that the genie will go back into the bottle. Next slide, please. And I just love this slide from the Cybersecurity Hub, from their Twitter feed. Who led the digital transformation of your company? CEO, CTO. For us and for many of us across the country, it was COVID-19. So thank you. Next slide, please. It's a pleasure to introduce my colleague and friend, Dr. Elizabeth Kropinski. I'm going to hand the mic over to her. Thank you.
Thank you so much, and my kudos as well to all the organizers of the this conference, and especially for those of you who have stuck with us this whole time. It's getting towards the end of the day in so many places, but it's great to see so many people still attending. Next slide. So you've got all this great information. You're either doing telehealth or you want to get into it, or, you know, as we ramp up, you want to continue what you're doing. Where the heck do you go to get some advice beyond a meeting like this, get access to all the stuff that's been talked about here and so on? One really great place is the telehealth resource centers. These are all HRSA funded. They've been in business, most of them for about 10 years or more. And they are there via HRSA and the Office for the Advancement of Telehealth to provide advice, technical advice, training, resources, outreach events, and so on to help people start up, enhance, sustain their telehealth programs. We all received an additional 1-year funding from HRSA, specifically to help providers and other groups use connected health platforms as related to COVID. This was a great initiative through the CARES Act, really recognizing the value of telehealth and the telehealth resource centers. We have all been developing, collecting, collating as much information as possible. We have toolkits, fact sheets, articles, you name it. We've been collecting it and trying to get it up as fast as we can collect it. There's just a lot going on. Everybody is posting these for free, public access and use on their websites. We also do a lot of one-to-one, I'll call it consulting, but it's really free advice for the most part. We have been putting on training events, webinars specific to COVID and telehealth. Blogs have come out, all sorts of virtual-based events to update the community on the various changes in policy, reimbursement, grants, technology, and so on. That's been happening. And it's not going to slow down, because after the crisis ends, as Karen and Jim and everybody's noted, telehealth is not going away. But some of the challenges are going to be, how do you continue beyond what a lot of people did, which is just kind of, here, let's start it up and get going in a time of changed waivers, regulations, and so on. I highly encourage you to go to this website here. There are actually 14 telehealth resource centers. There's 12 of us that cover various regions throughout the United States. And by the way, every state has a TRC associated with it. But a number of years ago, we formed what we called the National Consortium of Telehealth Resource Centers, and all of the information can be found here at this website. And you can go here and then look for your state, and then the website will connect you up there. So I highly encourage everyone to really go out and do that. There's a ton of funding out there, and this is just one example. The FCC, through the CARES Act again, has $200 million to help providers provide connected care services to patients at home or at mobile locations. They are basically taking this money, accepting applications pretty much on a rotating basis, and using the money up on the grants until it's all been spent out, or until the pandemic ends. It's a limited number of nonprofit and public eligible health care providers fall into the various categories that they're allowed to fund, but it's a great resource. The NIH as well has put out a lot of funding. In the new version that's potentially coming out now, that's in the legislature, there's going to be potentially another $4.745 billion to expand COVID research allocated to the NIH. That's going to be voted on possibly before the end of the week, but they've already received a ton of money. DOD, HRSA, all sorts of funding agencies are getting money to get us through the crisis and beyond. Next slide. So I kind of put a different slant on things here. I think we can use these waivers to leverage research and push the telehealth agenda. Our goal, a lot of us, is for telehealth to take over the world. I had a really cool picture on this with a particular cartoon character from Bugs Bunny, a little Martian guy that, his goal is always to take over the world. Well, that's telehealth's goal as well. There are about at least 80% of practices reporting up to 80% of their business being done via virtual health. I think we need to capture all this use data as much as possible and use it to maintain changes. That doesn't mean everybody has to go out and apply for grants and stuff, but there's got to be ways to capture this data, the various applications that people are using, provider types, what are the settings, what are the prescribing and treatment recommendations that are going out, how many echo programs have been established, how many telementoring programs have been set up to train our providers, our residents, and our fellows who can't come in and work, all via telemedicine, and particularly outcomes. I really want people to think about how can we push a research agenda in addition to addressing, the immediate need of the COVID crisis. And I think eventually this is, as Karen said, the genie's not going back in the bottle, but at some point, those federal regulators are going to say, do we have data to back all this up? And I think we really need to pay attention to that now. And as we expand our telehealth practices, to keep in mind that some metrics of performance would be very useful. So with that, I'm going to hand it over to our esteemed moderator for the questions.
Great. Thank you so much, Dr. Kubinski. So that was a great overview of what's been going on. And obviously, it was complicated before. It's less complicated, but I still think that, especially the fact that a lot of the states are determining, a lot of these regulations still keeps it a little interesting. So I'm going to follow with Dr. Kubinski. So it seems like the CARES Act has done a lot of great things for telemedicine. How does it impact telemedicine potentially in a negative way?
I don't think there's going to be a lot of a negative impact. I think what it could do in a potentially negative way is to change people's expectations about what they're going to be able to do as we continue. So clearly, we're all hoping that a lot of these waivers just expire and things stay status quo. Now, whether that's going to happen or not is a very good question. A lot of us think that it will, especially in terms of billing and coding and those types of waivers. Things like the interstate licensure, people being able to practice across borders, that's potentially going to change back. HIPAA almost definitely is going to go back. So we're not going to be able to use FaceTime anymore for our encounters in all likelihood. So if anything, people are going to have to scale back a touch on what they're doing now. That's a little more liberal than what people are expecting. I don't think that's a negative thing. I think it will be positive in terms of protecting privacy, security, and so on, and what we're doing. The other potential negative is a lot of what people have been doing and implementing on this very fast startup basis, because of the waivers and what we can do, the technologies we can use. It's been very low cost a lot of the times. You buy a webcam, you set things up, but a lot of the times, a lot of these makeshift systems are not integrated with the EHR. They're not using HIPAA compliant platforms. So as we go forward, people are going to have to, I think, invest a little bit more into their telehealth platforms, possibly than what they were expecting. I don't think we're going to be able to use a lot of these, I don't want to say jerry-rigged systems, but some of the technologies that we're using are not ideal. And so people are going to have to sit back and figure out how to really integrate a lot of these startups into the broader clinical picture of quote unquote, everyday normal, daily clinical routine.
Gotcha. Great points. Yeah, I had a feeling this whole FaceTime thing wasn't going to last forever, but well, you can FaceTime your grandparents still, but not necessarily via telehealth. So my next question is for Dr. Ruban. How's the CARES Act changed what you do with telehealth in relation to acute unscheduled care? Oh, I think you're on mute, Karen.
Here we go. Can you
There
hear
you
me
go.
now? Sorry.
Yeah.
So it's a great question. As you mentioned in my introduction, I led an institutional strategic plan for telehealth and presented it to our new EVP for health science. And it was like, oh, the budget is a problem. Oh, the ROI is a challenge. And so the one thing that was, we were like, on hold for some of the things we're doing. We have a broad telemedicine program, but what happened was come COVID-19, we were charging everything to COVID-19. So we have built out a huge infrastructure. And the most exciting thing that I have, and I'm grateful for Tim's participation as well, is that since it was on our strategic roadmap, and even if it wasn't, we're about to launch a virtual urgent care service, just like all of you guys are doing. And I'm so heartened. I want to take all of this data back. But Tim is going to be a part of that. And again, how lucky are we to have an informatics ED fellow that was rotating on telemedicine in March and April? Could that not have been more perfect? So, and that's different than obviously what we're doing with our daily virtual clinic visits, but to have this urgent care model is one. We have broadly, and we've used our COVID-19 funds to expand greatly what we've implemented in the emergency department and across our hospital in terms of isolation precautions with telemedicine. We call it ISOCOMS. It was a model that was stood up actually during the Ebola crisis, and we just virtually expanded throughout. And you know, the interim final rule from Medicare and the CARES Act has allowed us to A, procure more equipment, and B, actually get coverage for consultations that are provided using these technologies, even within our own hospital or from outside our hospital. Lastly, we've developed a daily rounding and urgent care telemedicine solution for long-term care facilities around our region, where in congregate settings, we've had very high prevalence of COVID-19 positivity and patients that have had to be transported to our hospital. So our pulmonary and critical care teams are making rounds and then unscheduled visits as are needed. So those are some of the things that we have implemented. You know, again, I want to see all of this sustained long-term, and I want to take the messages back from this meeting about your virtual care solutions all across the society. So thanks.
Great. Thank you so much. It's great insight. The next question is for Dr. Marson. Is there any part of the CARES Act that you think should remain post-COVID emergency?
Well, I see Dr. Ruban. So that's the easy answer of that is that it all should remain, I think, in our opinion. I think the telehealth advocates, you know, a lot of it is it's the lifting of restrictions. That's what it is. It's lifting of restrictions. And that, generally speaking, isn't the wrong thing to do. Payers, including CMS, have had the fear, and it's understandable. They were burned with teleprescribing, pharmacy, things like that. They fear that if they're going to lift the restrictions, that there's going to be this enormous flow of increase in charges and billings. And what we can say is that when you look at different states with their Medicaid policies, there are states that are more progressive and allowing, and there's those that are more conservative with a lot more restrictions, that those that have lifted restrictions haven't seen the blowing up or the blowing up of all the charges that all the payers are afraid of. And in many instances, payers are seeing an ROI on this investment with remote patient monitoring, and actually costs can be lowered with this. So I think that in general, and right now, what the health plans have a lot of money in their pocket right now with this COVID crisis because there's fewer patients in the hospital and all of that. So I think that in general, the answer is to leave all of the restrictions gone. However, again, there sometimes need to be guardrails. There's, most of us are doing the right thing for our patients with the right intentions, but you don't want the folks that are cheating the system. And when patients want to be seen in person, when doctors want to see their patients and feel that a physical exam is necessary in person, that shouldn't be cut short with this. And again, I think it's more incumbent upon us as providers to monitor that than the payers to lock that out. And then the third thing I'd like to comment on as a pediatrician is trying to do everything that we can to maintain the medical home. So with these interstate licensure restrictions lifted, that's great. So somebody in my community can call with maybe COVID symptoms and get a doctor in a different state, but that doctor may or may not, probably won't have access to that patient's medical record. They won't know anything about the patient's history. They won't know anything about the local and county policies, infection rate for COVID and things like that, or even if it's non-COVID related. So I do think that all of it, it sounds great that folks can do all of this from all over town, but we really need to do whatever we can to do. And I know this is the concept of the medical home may not be so tuned to emergency medicine physicians doing what you have to do, but really to be able to have providers within the network that know the patient, that know the family, that know the local resources, that have access to the medical record. And in a way, the lifting of restrictions might create opportunities for folks to kind of like lower those medical home standards. That's my concern. Thank you.
Gotcha. Great. Thank you very much. So we'll take a question from the audience. So this I'm going to direct to Dr. Ruban, and obviously any of the other panelists, feel free to chime in. What are the most important data types that will be helpful to lobby for persistence of regulatory relief post-COVID? For example, payment parity, originating site home, elimination of rural restrictions.
So, both at the federal and state level, costs are taken into account. The Congressional Budget Office, scores all of these bills, and they are somewhat challenged in terms of having the data. So I think the CPT code data that have been expanded in this COVID crisis will provide a lot of data that will inform the Congressional Budget Office as they score bills going forward. The same is true for state Medicaid programs. Unfortunately, even the state Medicaid programs don't necessarily align with the same CPT codes and place of service codes and modifiers that the federal programs use. But I think if we can get information from the big payers, which are Medicaid and Medicare, we can use the data to gather data on outcomes, on true costs that will drive policy decisions going forward.
I think also, just a little bit to add, the CPT codes are important, but also potentially the ICD codes. So we know what department things are coming from, because not everything that's happening is absolutely COVID in terms of diagnoses and so on. So there's a lot of other stuff going on, plus things like encounter length. Now, some of the CPT codes incorporate that, less than 15 minutes, half an hour, but not all of them do. But I think it's also important where the patients are located. Whether you get that through city, state, zip code, whatever specific way of doing it, I think that's important, especially the type of location. So whether we're going into the home versus a clinic versus something else. I think also, some other possibilities are, the types of providers. A lot of the regulations that have been waived and so have been for MDs and DOs, but there's a ton of practice going on with various types of nurses, with PT, with OT, SLP, pick any initials you want, RDs. Everybody is wanting to do telehealth, but a lot of the regulations and the waivers have nothing to do with these folks, and they're still kind of sometimes stuck in limbo. So I think it's important to record that as well, and that will open up the doors for so many of these other allied health professionals and doing so much really, really good work that people, especially on the legislative side, don't tend to ignore, but aren't especially aware of as they are with MDs and DOs.
Great comments. So, maybe I'll ask the panelists. So did you have any aha moments during this entire process? Like, COVID happened. Now you're leading your telemedicine programs at your own institutions. Tell us about some maybe surprises or aha moments during this entire process and what you learned from it. James, I'll let you answer that one.
Oh man, I was waiting for. So I think I started off with mine. I think that I had been on planning committees for hospital preparedness, emergency preparedness, and but again, I'm a critical care physician, so I was looking through things through a lens. I'm thinking about, hospitals being overwhelmed in an adjacent county and how our hospital and specialists are going to be able to help them in those counties and things like that, or maybe a scene area where satellite telecommunications and triaging can be done. And the biggest explosion has been with primary care providers seeing their patients in their home to stop the spread of this disease. And maybe, again, that's my bad for not.
James, we can't hear you.
I can't hear you.
Okay, all right.
I can give you my aha moment.
Yeah, go ahead.
For a very long time, we have, Epic is our electronic medical record, and we had a steady stream of encounters, not including primary care, as Jim alluded to. And it took a long time to create the workflows for every single service line. Suddenly, when in-clinic visits dropped by 90%, everybody was willing to make the changes. And that was an aha moment for us, is that we could do this, and we could do it fast, and we could transform what was a strong program, but not integrated into primary care, not integrated into emergency medicine, into something that that we can do as a system. And it happened very quickly, and we scaled. I would say we scaled from 300 visits a month to more than 20,000 visits a month, and that was transformational, and that was really driven by COVID-19.
I think the other thing that I would add to it, sort of the aha, speaking from sort of the perspective of the Telehealth Resource Center, where people started to ask for advice and stuff, was how sort of basic the questions really were. People were I could put them in two buckets really. How do I start? So what the heck kind of platforms are out there, and how do I do it on the cheap? And then what are the billing and coding? And those are the two main buckets. People really were very much less concerned with HIPAA, the licensure issues and so on. We got those kinds of questions too. But so much of it was, yeah, we've heard about all this, and we were kind of on the fence before, and we were sort of looking into it, and now we really got to do it. Oh my God, what do we do? And so they were looking more for just real basic advice, and what tools and platforms are out there.
Great. So obviously, a lot has changed, and I do think that, some of the reluctance on implementing telemedicine obviously was the reimbursement aspect. So now, due to the CARES Act, they are going to reimburse now as in-person visits. Now, do you think this is sustainable in the long term? Because right now, a telemedicine visit, you could basically get reimbursed as an in-person visit. If we don't have the data, what other hiccups do you think we will have to deal with in the next, say, 2 to 3, 4, 5 months? Is this sustainable to keep continuing to bill as in-person visits for telehealth?
I think we can, and I think what's going to drive it is patient demand. Patients are realizing now that, I don't have to drive 2 hours to see my provider for 15 minutes and then drive all the way back home. This was an option all along. What are you doing to me? So it's going to be patients that are going to drive this, and they're going to talk to their, more than ever, talk to their providers, their institutions, to their legislatures, and so on, and they're just going to demand it. And that's what's going to drive it more, I think, than the providers and the institutions.
I agree.
You heard Jim.
Karen?
Yeah, no, I totally agree as well. And, we will advocate. All of the specialty societies need to be doing so. I think that there are opportunities for Corey grants, ARC grants, to aggregate, present the evidence from which all of these decisions will be made. And I agree with Elizabeth that patients are saying this, why couldn't I have done this before? And maybe the outcomes will be better, that we can demonstrate better outcomes at lower costs in the end. And for Medicaid programs, remember, many state Medicaid programs actually pay for transportation of patients. So this is even a cost savings for Medicaid. The bigger problem that I've experienced, and I just finished a term as board chair of Virginia Medicaid, the states themselves are having financial challenges right now. So, as the states look to expanding Medicaid services, their own budgets are challenged because of tax revenue is down. And so it's really important that we have great evidence-based data to help them continue these changes.
Great. There's a question along the same lines. It says, payers are likely to call for guardrails to mitigate risks of misuse and overuse of telemedicine services. Dr. Martian mentioned one of these regarding maintaining a medical home. What guardrails would you suggest can appease payers to allow waiver to be maintained post-COVID?
I don't know if you can hear me. Go ahead.
We can hear you.
Oh, I'm sorry. Well, go ahead. You can comment, Dr. Ruban or Kopinski.
Well, fraud and abuse are always a concern. And, evidence-based guidelines are very important. I think I haven't looked across the nation at the commercial plans responses, but the commercial plans have generally been relatively conservative. When there are private pay parity mandates, they are obligated to step up. But in those states, some of those commercial plans have stepped up and done so as well. So I think they have the rules, for their own beneficiaries. But I think that if we can show cost savings, improved outcomes, we can bring them on board as well.
And if I can just add one thing, I think that there are health plans, at least in California, that have kind of carved out telehealth services to third-party providers with these companies. And I've had personal experience providing a consultation to a patient with complex chronic congenital heart disease, and then being denied that payment in that health plan, saying, oh, well, we have it carved out with such and such company. And that's really annoying. It's not good for patient care. It might be a little bit cheaper than my codes, but I think that guardrails, I think, with the patient in mind, focusing on quality of care and doing what's right. I can understand those being in place.
And I would like to reiterate what Jim said about providing care through telehealth under the construct of the medical home. I think there would be less fraud and abuse that creates those concerns, because it is part of the patient's medical home, whether it's specialty medical home, primary medical home, or the urgent care model.
And I think part of it's going to come down to training and education. So you've got, for example, an effort by the AAMC to develop core competencies. A number of us are on that committee. And so as our new generation of providers comes out, they're going to have telehealth as part of their foundational education. And I know the nurses are getting this already. So as it spreads and as we realize how important this is, people are going to be trained in this, and they're going to understand the ethics of doing telehealth more than I think the current generation might even know.
Yeah, great point, Elizabeth. I'll tell you, just on a personal note, we have been focusing a lot on training, even pre-COVID, and I think medical schools and residency programs and organizations are going to have no choice but to actually train, people in this website manner that we talk about. It's essential, and it is really an art and a skill that you have to learn. It's not just like FaceTime. So I agree. So we have a couple minutes left, and what I'd like to do is maybe just have a few key takeaways from each of you. Any tips, advice, what for the people on this webinar and that they should be aware of.
I can start, and I would say utilize your telehealth resource centers. We're also a telehealth resource center out in the Mid-Atlantic region. So I would say absolutely, because there are such incredible resources at the telehealth resource centers themselves. I agree about training, and I think we need to learn from one another and advocate together. And this is a very strong society that should be able to advocate at the federal and state level on behalf of our patients and our systems themselves.
Well, you just stole all mine, Karen.
I'm sorry.
But I think the only thing I would add is, it really is important for training, and to not reinvent the wheel or try to do it on your own. As Karen noted, there are resources out there. There are programs, a lot of them for free or very low cost, that provide training in telehealth. And, if you're going to get into it, it's great to do it on a quick and startup basis. Maybe do a few dry runs with fake patients before you start, just so you kind of get it down and you know what the glitches are going to be. But it really is a great adventure, I think. And, it is an important cause, but I think there's just such an excitement about doing telemedicine that it can be fun as well. I mean, I know it's a crisis, and I know, there's implications for care and so on, but it really is going to be what we're doing in the future. So learn it now.
Right.
Thanks. I might just maybe add that, I've been pre-COVID doing a lot of these, as I'm sure many of us have, like advising and counseling folks that want to start a program. And as we've recognized with this, it's your health system, your hospital, you can't be just like adding on 10% and you do this, you do this. You know, it takes a real investment to be able to build a program like this. It's a serious one, and it's absolutely the future. Remote patient monitoring, chronic disease management, all of this is going to be the future of healthcare, and it's going to take a significant investment on whoever it is that holds the purse strings on your health system or provider network to be able to invest in this. And so it's like, I always say, it's like starting a liver transplant program and stuff like that. You can't do that by saying, oh, well, I'll pay you 10% for this and 20% for this, things like that. It takes an investment.
And I think also, as Elizabeth alluded to, there's a lot of money out there for grants right now. And this is a Society for Academic Emergency Medicine, so urge you to explore funding opportunities that can have lasting implications in terms of public policy.
Karen, you're increasing competition.
It's okay. It's for the patients.
Well, listen, I sincerely appreciate all of your insight. I mean, this has been such a great panel with such experts. We're honored to have you, even though you guys are non-EM physicians. It's our honor to have you on this panel and really reflect on your experiences. With that, I'm going to hand it back to Dr. Hayden, who's going to conclude. But once again, thank you so much to all the panelists.
Great. Thank you so much. Thanks, Dr. Sharma, Ruban, Marson, and Krupinski. And I can't agree more with the statements about both the telehealth resource centers. Your websites are great and have such great information. And then also I agree with Dr. Krupinski that I'm sort of a telehealth geek. So yes, I believe that telehealth will take over the world. So on that note, I really appreciate everybody sticking through all this. It's a long day for emergency medicine physicians to sit in chairs and watch screens. So I want to thank Dr. Hollander and all of our panelists and moderators for sharing the lessons that they've learned with us today. And I also want to thank the content experts who answered the questions during the presentations and the planning committee for planning this conference. The future is open to apply and use the experiences we have heard about today. We are beginning to experience how this pandemic will impact emergency medicine. Today, you heard many examples of innovations, and may these be the catalyst for your own innovations. Let us continue this conversation at SAEM 2020 Consensus Conference in September. Help us develop a research agenda on the topic of telehealth and emergency medicine. All of our expertise has served us well through the COVID time, and thank you everyone from everywhere for everything you have done. Stay safe and have a good day. A reminder that this recording will be on the SAEM website, and the questions and answers will be transcribed from the Q&A box on the website. And I'm ending a little bit early here to give some time back in your day. So thank you, everybody.